Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. Honorable speakers, respected guests, good morning to all of you and welcome to the Placenta Accreta Spectrum Symposium. We will be starting our lectures with the first consultant, Dr. Lamia Musa Al-Madan, Consultant Obstetrics Gynecology in Security Forces Hospital. She had her Master's of Science, Quality Safety in Healthcare Management, Certified Professional in Health in Health and Hospital Management. She's member in Saudi Obstetric Gynecology Society, Saudi Maternal and Fetal Medicine Society, and the Saudi Simulation Society. She will be presenting to us and enlightening us about the introduction of placenta accreta spectrum and the risk factor. Welcome, Dr. Lamia.
Why do we have to talk about placenta accreta and placenta accreta spectrum? Placenta accreta, it's have a lot of reflect on the maternal mortality and morbidity. It is really matter to talk about these things, because if we want to start to calculate our risk in our patients, so we have to think, is the placenta accreta a consequences of something or it's a real risk? By the definition, placenta accreta is a risk with a lot of consequences. So we have to work a placenta accreta spectrum as a risk, and we have to assign a risk management plan with a risk owner, and in this way we could manage placenta accreta in a better way. Placenta accreta spectrum is a general term used to describe abnormal trophoblastic invasion in the myometrium, and sometimes to be beyond the serosa. So the classification placenta accreta spectrum, there is a traditional classification and there is a FIGO classifications. And there is no much difference between the traditional classification and the FIGO classification, where placenta accreta, it's called when the placental villi attached to the myometrium but not invading the myometrium. This will be called accreta. In creta, it is invaded to myometrium, and per creta, it is beyond the myometrium to the serosa and the adjacent organ, and this is the traditional classification. If we are going for a FIGO classification, grade 1, it's equal to placenta accreta, where it is just attached to the myometrium. Grade 2, it is invading the myometrium. Grade 3, here is the difference between the FIGO and the traditional classification, where in grade 3, it's have a 3 level, 3A, 3B, and 3C. The 3A is limited to the uterine serosa, and 3B, it is invading the urinary bladder, and the 3C, it's invading the adjacent organ. And believe me, I hope that none of us will see grade 3C. I saw it once in my life, and I hope I will not see it again. It is really a nightmare. The prevalence of placenta accreta, it is 0.003 in the 1950. In the 2019, it's increased to 0.17. And there is a real statistical significant increase in the placenta accreta overall. With a placenta accreta, it's forming 63% of the total accreta spectrum, 15% in creta, and the 22% is the placenta per creta. The pathogenesis of placenta accreta spectrum, if we look for it, we will find that 90% of the patients with the placenta accreta spectrum have a history of a previous cesarean section and curettage and myomectomy. And the majority of it is a previous cesarean section. That's why when I look to the agenda and I find that they including how to reduce the risk of the cesarean section, and I feel very happy, and I'm looking forward to see and to hear this lecture, because it is really the first cesarean section. It does matter. It's the consequences of it is very high on the patient and on the OBGYN team as whole. In rare cases, uterine pathologies such as bicornuated uterus, adenomyosis, submucous fibroid, myotonic dystrophy, affected previous radiation therapy could be the cause. The Silver et al. In 2006, they studied 723 women with placenta previa undergoing cesarean delivery. The frequency of placenta accreta spectrum increased with the increase the number of cesarean delivery. And when we look here, we will finding on the right, in the left side of the screen, the presence of placenta previa, and there in the absence of placenta previa. So we find that, or they found that in the first cesarean section, the placenta, with the placenta previa, the placenta accreta spectrum is 3%, whereas if there is no previa, in the first cesarean section, it is 0.03%. With the second cesarean, the risk will be increased if there is a placenta previa to 11%. And without previa, it's 0.2. In the third cesarean, it's 40%. And see how much it's going up. And in the third cesarean, 0.1%. When the fourth cesarean, it's 61%. And without previa, it's 0.8%. And in the fifth cesarean, it is 67%. And in the fifth cesarean without previa, it is 4.7. Just by looking to this is give us a clue. If I'm going to label my patients and we have a high risk alarm, we introduce a high risk alarm for patients following up in our antenatal care to the system. So once the patient is logged in, you will see the high risk alarm there. And why we put this high risk alarm? Because we want the doctor who is following up the patient to look why she is high risk. If she is high risk for recurrent cesarean section or even previous one cesarean section, when she is doing the 18-20 week ultrasound, she will dig deeply. Our brain will look for the things if he recognizes it. In other words, recognize the thing if he is looking for it. If I ask all the people here in the room, once you are entering the room, enter the room, close your eye, how many objects in this room a green color? Believe me, 80% will not be able to answer the correct answer. But if before you enter to the room, I will tell you, I will ask you how many objects in the room have a green color. 80% they will get it. So we'll teach our resident, we'll teach our senior registrar to look for a placenta accreta spectrum in particular high-risk patient. Starting by their history, which is the most important, and a lot of our colleagues, they think that the history is not important. It is the soul of medicine to take deep history, and exact history is the patient did any operation, did she is having a previous cesarean section. Then we will go with the examination, which is the detailed examination, not only the biometry. Always I teach my colleague, my junior colleague, then look for the placenta. The first thing, viability. The second thing, placenta. And when you look for the placenta and you find low-lying placenta, then open your eye. Low-lying placenta is associated with 1, placenta accreta spectrum, 2, vasa previa, 3, and so on. So you teach your junior colleague, and this is our responsibility as a senior people, senior, not old, to look deeply whenever they are having, and I advise you all to activate this. Most of us now is electronic file, and with the help of IT, you could activate the high alerts of high risk. Some of the system, they have it already built in. Some of the system, it's not built in, or you need to activate it. So placenta previa increase the risk of the placenta accreta spectrum. Other risk factor like history of uterine surgery, whether DNC or myomectomy, hysteroscopy, coronary section of the ectopic pregnancy, or endometrial ablation. And there is remote risk factor like it's coming by incidence, 35-year-old, multiparity, history of pelvic radiations and manual removal of placenta, postpartum endometritis and infertility, and multiple gestation. And I remember one patient, she entered to the delivery, she's para 2. The first delivery was normal completely. The second delivery, the patient's placenta was retained, so they took her for the manual removal of the placenta, and when they look for the placenta, there is one lifted cytolidome. So the doctor, she's insisting to remove that remaining cytolidome. I wouldn't. Believe me, I wouldn't. Either it will come by itself or leave it. So when he removed it, it was implanted in the myometrium. He failed to control the bleeding. Patient ended up by hysterectomy. So we have to learn from our story, from the story with our colleague. In the clinical presentation, the majority of placenta accreta spectrum is firstly suspected by ultrasound examination. And the first clinical manifestation of placenta accreta spectrum is often profused life-threatening hemorrhage that occur when attempting manual placenta removal. And the biomarker, like maternal serum alpha-fetoprotein, is increasing by 2 to 2.5 per multiple of median. But there is no strong correlation with the placenta accreta because it is associated with another causes. So we couldn't use this marker to diagnose or to screen for placenta accreta spectrum, which is leave us with the first cubicle that placenta accreta spectrum history and a first examination by ultrasound, whether dating scan or the first patient, the first time she's coming for us. Hematuria also can be presented, the placenta accreta spectrum, especially if it's 3C, with the invading of the bladder, or 3B. In this situation, you might do cystoscopy, but don't expect it a lot because sometimes it is micro-invasion and it's coming with hematuria, with gross hematuria, but it's not mandatory to have something really in the cystoscopy. Placenta accreta spectrum, all the people who's attending here, all of us, we know it is a tornado. Once you diagnose placenta accreta spectrum, it is my nightmare to go for a cesarean section. Always I pray before and I pray after the placenta accreta spectrum if the patient is saved. Priority for a mother, that's true, but we are facing also this scenario. I hope that we will not lose, but this is one of the complications of placenta accreta, to lose a patient. A study done by in 2015, and about 356 patients with placenta accreta spectrum. The most common morbidity is massive hemorrhage, DIC, adult respiratory distress, renal failure, unplanned surgery, maternal death, bladder injury, 5%. Other complication less than 2%, urinary tract damaged, genitourinary fistula, bowel damage, thrombotic event, wound infection, and hemorrhagic shock. So if we look to this, all these complications, we could say that the complications could be either due to the recurrent cesarean section where you can injure the bladder, you can injure the bowel, or you can have prolonged operation and ended up by pulmonary embolic disorder, or due to the massive obstetric hemorrhage and the massive obstetric transfusion. Always I think that we have to train our also junior colleague how to handle a massive obstetric hemorrhage from the beginning, because it is very important. A lot of people concentrated on medical management only, give methargine, give carpetocin, give carbobro. What about the IV fluids? Where is the IV fluids? Where is the resuscitation? Did you cross match? Here it's make a difference. So always I urge my colleague to concentrate whenever there is a placenta previa and placenta accreta, to teach the junior colleague that the resuscitation, it's the soul of survival of the patient. Increased maternal morbidity with more severe diseases. And remember that placenta accreta spectrum, when the patient ended up by hysterectomy, the impact is not only physical impact, it's also psychological impact. And we saw a lot of patients. So whenever you are facing such a patient, get the help of psychiatrists. or at least psychologists if you have with your patient. Don't forget this point even when you follow up your patient, because the consequences and the complication, it's really matter for the patient and for her husband and for her children. In neonatal morbidity also, the preterm, small for gestational age, and the maternal mortality. There is a study done for 442 patients suspected placenta accreta spectrum, International Society of Placenta accreta spectrum. They claim that even that they have massive blood transfusion higher than 20,000 ml, 88 patients with a placenta invasion into the bladder and beyond, there is no maternal death. The author comment by himself. The author are aware of the maternal death that occur each year in high-income country, most of which are unreported. And what happened? We are afraid to report. We don't want our reputation to be ruled out. So any patient, if she die on the table, she die. But if she die in ICU, no, she die from infection, she die from renal failure, she die from... Actually, the consequences of the events should be counted on when we are calculated. And we know it is, again, it's our nightmare. So prenatal screening and diagnosis. Do you have to do screening? Who think that we have to do screening raising their hand? So good that we have a good amount of people, they think that we have to do screening. Why? Because the patient can be counseled about the suspected placental abnormality. Appropriate site and plan for delivery can be done. Transfer the patients to tertiary center. And here I will tell you a small story. Still I have time. One time, one patient, she is previous recurrent cesarean section, and she said, Doctora, I heard about you and I want you to do it for me. I tell her we are in a secondary hospital and we don't have a good blood bank and we don't have urologist. Please go to the teaching hospital. I have my colleague over there. I can call her and she would accept you. Then the patient said, no, I will not go. I will come when I have bleeding and you will do my cesarean. Then I said, okay, stay in the hospital and we'll do it electively. We did the elective cesarean section, and the patient, at the beginning, we managed without hysterectomy. After 5 minutes, 10 minutes, 15 minutes, patient started bleeding. We went back and we did hysterectomy for her. The patient, I cry. I never cry on a patient. I cry because the patient in ICU, I don't have blood for her. And when I said I need the platelets, they said, we will search. Then the first term of my life, I say this statement, why I entered this branch? Which I regret that I say this statement. But at that minute, I cry like a baby because I'm going to lose my patient. No blood bank. So don't hesitate. You are in secondary hospital, send the patient to tertiary hospital. Tertiary hospital, there is a urologist, there is a blood bank, they can call. Maternity hospital, they are very rich. We are not rich, we are very poor people. So starting sending the ambulance to the regional lab, searching here and there to find a platelets for a patient. And once the patient, because she entered to the IC, she received the platelets, her picture completely went normal, and it was Eid. So me and my colleague, we spent the three days of Eid in the hospital because we cannot leave her. So again, tertiary hospital is very important. Knowing our limitation is very important, and we have to stress in the patient that they have to. But sometimes still we are facing such patients who don't want to move. So we pray. Pre-operative preparations, including availability of blood, informing urologist, informing expert anesthesiologist. And here always I'm saying a story. I'm old enough to tell a lot of story. I have one time, one brilliant anesthesiologist. We are going for a patient with, how many minutes I have? We have a brilliant anesthesiologist, and the patient, she came and she was, this is my first, and I hope it will be the last, placenta previa, opened by one of my colleagues, and she didn't dig deeply for ultrasound. The placenta was invading the pelvic wall. And the patient arrested on the table, and they call me. come and help. What I will do? Okay, we will help. Hysterectomy done within 13 minutes. What else? Internal artery ligation, useless. Then not by general surgeon, internal artery ligation done by cardiovascular. Then we start the blood transfusion. Then I said, it's here, this area. If I close it, the bleeding will stop. Then the cardiovascular said to me, why you didn't close it yet? I said, because the ureter is here. He said, close the damn ureter. So I closed it and the bleeding stopped. So this is, I remember how the anesthesiologist react. He was brilliant. He called 4 anesthesiologist consultant, each one on arm of the patient, and he started giving an order, and the patient survived. I still remember that we need a strong team, and we need somebody who is subspecialized in obstetric anesthesia. We hope that we reach to this time in every hospital. To whom we have to do the screening, we said for any patient placenta previa, low anterior placenta, prior uterine surgery, how it will be done, transabdominal or transvaginal, and when to do it between 18 to 24 weeks or whenever the patient's appearing in our clinic. So do we have to do ultrasound and MRI, or we have to do ultrasound alone, or we have to combine both? Which is superior to which? I don't know if we have a lecture covering this part, so I wouldn't touch this part. But remember that MRI have a rule in posterior placenta, possible, and the patient who is the depth of myometrium, it have superior rule, and evaluation of placenta border when you are thinking about hysterectomy. Combination of MRI and ultrasound interpreted by a physician with expertise in this area, it is our aim. Remember that whenever you are an expert or you have somebody expert in ultrasound, a lot of time they are superior to the MRI in diagnosis of the invasion. Safety of the patient is first, and I believe that placenta accreta spectrum, it is a risk. So please, starting by myself, to write a risk management plan for placenta accreta spectrum in our hospital. Thank you very much.
Educational journey now. We will have our second lecture with Dr. Iman Abdul Qadir Sulaiman. She had completed her Saudi board training and had her diploma in ultrasound and obstetrics gynecology. She's the head of the ultrasound unit and working as a sonographer specialist in Maternity Children Hospital, Dammam. Please welcome Dr. Iman. Her lecture is about the ultrasound diagnostic imaging in the placenta accreta spectrum.
Today, and my talk today is about ultrasound diagnosis of the placenta accreta spectrum. And I would like to give you some points about my lecture. It will be divided into 4 parts. First, pathophysiology. Then we will go through the normal ultrasound sign in normal placenta. Then in comparison to abnormal accreta, placenta accreta. Then we will end by a fresh case we have diagnosed, and it was done before 2 days. Now we will start with the pathophysiology. Prior to implantation, the endometrium will be converted into superficial layer and deep layer, which is deciduo compacta and deciduo spongiosa. Then we will get the myometrium. In normal placenta, after delivery of the baby, there will be division of the or separation of the placenta from the deciduo spongiosa at this level. But in accreta, what we have, why we have the problem? Because in accreta, it's adherent to the myometrium. In creta, it's infiltrating through the myometrium. And in pericreta, it's penetrating through the whole thickness of the myometrium, and it's going to the serosa and maybe to the adjacent organs. So now we have adherent placenta and invasive placenta. Adherent placenta is placenta accreta. Invasive placenta is increta and pericreta. So what's the pathology behind this? We have deep endometrial defect and avascular hypoxic milieu. And a deep endometrial defect is when we have, example for this, when we have a previous scar. So there will be defect. The placenta, all we know, the placenta will grow on through and through till it gets its nourished and vascularization, good vascularization. So it will be deeply invading till it gets the vascularization. Also, avascular hypoxia, when there is extensive curettage, severe endometritis, and also aggressive manual removal of the placenta, there will be avascular or scarred area in the uterus, and the placenta also will grow through and through to get its deeply, to get its vascularization. So some of the risk factor, Dr. Lamia already she mentioned, but these are the important one: previous cesarean section, anterior placenta previa, deep endometrial damage, extensive curettage, manual removal of adherent placenta, postpartum endometritis. And I want to emphasize on the first two: previous cesarean section. As Dr. Lamia she mentioned, the history is very important, and if the patient has multiple abortion, just dig in the history how the curettage was done, how difficult the curettage was done. Maybe the patient will give you a hint about this. Also, anterior placenta previa, because if you don't find anterior previa, you will not look for the other signs of accreta. If you look for the other signs, you will find ما في مو سامعين. Okay. If you look for the other sign and you find some false positive vascularization, you will end up with the dilemma with the doctor. You will just tell them, yeah, I have seen this vascularization, but the patient has no risk. And where does the problem lies now? Is it in the uterus or in the placenta? In the past, they were thinking that the placenta is the one who's getting us this weird behavior toward the uterus. It's abnormal placenta. It's invading through and through. But nowadays, they believe that it's the uterus who will stop the placenta from invading more and more. So if you have good endometrium, it will stop that invasion. Now we will go through the ultrasound normal placenta sign. Ultrasound signs are present in 80% of cases of an abnormally invasive placenta. Antenatal detection occurs in 35% cases. Why? Because the typical sign of placenta accreta won't be visible until late in second half of pregnancy. And most of our patients will not come in this, will not scan them on this. We will miss this population of patients in this period of time. So now I just want you to go through this video. Yeah, and we will talk about it. What you can see here from above, you can see the abdominal wall, rectus sheath, then hypoechogenic area, which is this thickness is our uterus, then the hyperechogenic mass with some small translucent area. So this is a normal placenta. So this is a screenshot from that video. So what I will concentrate on the ultrasound. Always when you go to the ultrasound, just put in your mind the points you will concentrate on. First, identify your urinary bladder, your mucosa. This is the thickness of my uterine wall, and this is hyper-echogenic mass, homogeneous. There is no interruption in this placenta. Now, you will look more. There is a clear zone. This is what we call hypoechogenic line between the placenta and the uterine wall. You have, if you don't find this clearly, just you have to look to the picture and you will say, yes, this is a placenta and this is uterine wall. This is enough. And of course, you have to find a continuous uterine wall with good thickness. Now, this is the thickness of the myometrium. It's good in this case. Bladder wall, it's straight, hyperechogenic, straight, no interruption in that one, no bulging. So this is, we will compare it with the sign we will see now. This is, that was colored scan, and this is the grayscale scan. Just see, notice the hypoechogenic here, hypoechogenic line. This is the clear zone he's showing you. So this is the placenta. This is hypoechogenic line, and here is the thickness, and here is the hyperechogenic line of bladder mucosa. Now, this is posterior placenta. In posterior placenta, it's difficult for us to diagnose placenta accreta because we don't have bladder. Okay, bladder will help a lot. So you don't have bladder, and also in obese women and in posterior placenta and obese women, and when you put a lot of pressure also on the abdomen of the mother, you won't be able to see the myometrium. These are the three cases that you will not be able, or three situations that you will not be able to identify the myometrium. So in posterior placenta, always, most of the doctor will prefer to go for MRI for the diagnosis. Now we will go through the accreta, placenta accreta spectrum in ultrasound. We will compare that with our normal one. So ultrasound cannot reliably distinguish between the three types. Yani the doctor, when he will refer the patient for me, I will not tell him, maybe between accreta and pericreta we will tell, but in creta, it's somehow you will discover it on the OR. And it may, all of them will present at the same case. So now I want you to take a look of this video now. What we are seeing, here is our abdominal wall, here the bladder, and we can see heterogeneous placenta. All this is heterogeneous placenta with numerous lacunae, translucent area interrupting this our placenta, and also there is a bulge, and can anybody see any myometrium? No myometrium. Bulge also we have, so thinning of myometrium. No distinct or echogenic clear line of the mucosa we cannot see, and also numerous lacunae. In this case, I can say that 80% or not more than 90%. This is in OR. It will be placenta accreta. So, what are the B mood signs? That's all what we have. This is only revision. Abnormal placenta lacunae, loss of clear zone, myometrial thinning, a placental bulge, and bladder wall interruption. So we will go through this. Now we are comparing the normal with the abnormal. Can you see here? Can you appreciate here the homogeneous placenta and heterogeneous with a lot of numerous translucent lacunae? Here, clear, good thickness of myometrium. Here, we can see it. And here also straight line, hyperechogenic. Here it's interrupted and not clear. This is a colored one, the same. This is abnormal lacunae showing you. Here in the right side of the slide, you can see a numerous lacunae. Here you can see the loss of clear zone. Loss of clear zone in this part. And myometrial thinning, you cannot identify any myometrial thickness. Here also we have placental bulge. This is what we have got in our case. I will show you now. And here also we have a bladder wall interruption. And one point also, if you see bladder wall interruption, don't be sure that it's invading the bladder, because you cannot say it's invading the bladder until you see exophytic mass there in the bladder, and it will be very clear for you. Now this is the same, only you can appreciate now after we have discussed. Now the color Doppler sign. So we finished with the B-mood Doppler sign, now color Doppler sign. Uterovesical and subplacental hypervascularity, bridging vessel, and lacunae feeder vessel. Uterovesical subplacental hypervascularity, easily you will get if it's placenta accreta. But bridging vessel and lacunae feeder vessel, it needs a lot of experience and practice. So this is a picture of what subplacental hypervascularity. You can see this is the mucosa of the bladder, and here is the hypervascularity, and it has to be on the maternal side, not in the whole placenta. If you put your color Doppler and you see the whole placenta is flashing like this, be sure that you are doing wrong practice on this. So you have to correct your color gain. Here also what he's showing you, can you see this tortuous one, a blue one? It's coming from the hypervascularity to the surface of the bladder. So these are the bridging vessel. The other one, he will show you, these are the feeder vessel. Can you see the blue one going into the lacunae? These are the feeder vessel. It will come from the hypervascularity to the lacunae itself. These are the flashing ones. So false positive and pitfalls. Like in this video, he will show you first the wrong, what he's doing wrong here is increasing probe pressure. Now he will release the pressure and you will see the full thickness of the myometrium. Before it was increased, so there was no thickness approximately. And now here you are seeing, just notice this lake. This is a lake. It's going to the surface of the placenta, so it's not going here. So this is not lacunae. Even it has a flow. What I have noticed that When you have a lakes, you will have a flow. If you have the lacunae, there wouldn't be any flow in it. So can you see the flow there? There is a flow. So if it's on the surface of the placenta, this is a lake. And also, it doesn't have any other sign. Here, a grayscale ultrasound, and what you can see here, continuous mucosa with a defect over there. This is not a defect. This is only, this here is not a defect. This is only a wrong angle. If you get it from another angle, it will be continuous. So this is a previous scar with thin lower uterine segment only. But it's present, not absent. Yeah, what we are getting here, the placenta, the whole placenta is getting flashing with a color. So this is pitfalls also. This is hypervascularity. But it's in all the placenta. So we are doing something wrong here, which is we have to correct our setting. If you see here, here is hypervascularity in all of your placenta, but there it's in the maternal side only. So that one is the wrong. Is the right. So it's incorrect Doppler setting. You have to decrease your gain color. High sensitivity and specificity. Previous cesarean section, anterior placenta previa. This is in your history and in your ultrasound, and also abnormal placenta lacunae and loss of clear zone. You just to concentrate. If you don't get the other sign, concentrate on these, and you will end up, inshallah, with the diagnosis. Now, our fresh case, it was before 2 days. It was referred from Nairiya, I think, Al-Hassa, previous 3 CS with 35 weeks. And it was referred as placenta accreta. During our scan, we have noticed that there is a bulge, and we diagnosed here as placenta precreta, and it was, alhamdulillah, after delivery, it was right. So what we will get here, thickness of the myometrium up. Here, you can't see it. But as you go down, here there is no thickness. It's only placenta. And you can see here from this angle, there is a bulge also in the bladder. See from this one, it will come now. And there is a lacunae also, but it's small. But we didn't get here myometrium, and we didn't get clear zone. This is only placenta. And also, there is a bulge here. We can see the bulge. Yeah, and here you can see the vascularization. Again, the vasculouterine vascularization. If you see this one, it's very short. Here, this is the bridging vessel. The same here, you can get this, like the feeder vessel. These are the feeder vessel. And here during OR, This is the bulge we have, they have seen and they have got, Dr. May and Dr. Zahra. And yeah, this rosa, this is what we have said, because there is a bridging vessel, but there is no mass invading the bladder. So we can't say it's invading the bladder. Here is the bulge with the placenta. And thank you.
سعادة رئيس تشغيل مستشفى الولادة والأطفال بالدمام الأستاذ مساعد بن حمد حضورنا الكرام، السلام عليكم ورحمة الله وبركاته. يسرنا أن نلتقي اليوم بمؤتمر طيف المشيمة الملتصقة والمعتمد من هيئة التخصصات الصحية بواقع 14 ساعة، حيث تكون البداية مع كلمة رئيس المؤتمر دكتورة نيلة أمين، فلتتفضل مشكورة. والسلام على أشرف المرسلين سيدنا محمد عليه الصلاة والسلام. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. نشكر حضوركم جميعا بهذا اللقاء العلمي الذي أظنه هو الأول من نوعه في المنطقة الشرقية، وإحنا اخترنا إقامته في هذا الوقت بالذات تحديدا لأهمية الموضوع ولزيادة عدد الحالات التي نقابلها في كل المستشفيات. كون مستشفى الولادة والأطفال مستشفى مرجعي للمنطقة، يعني واجهنا فيها بعض المعوقات، لكن في زي التشالنجز يعني كانت تحديات بالنسبة لنا عشان نستقبل هذه الحالات ونتعامل معها. بقول لكم على برزنتيشن كده بسيطة بس تعطيكم فكرة عن مستشفانا. مستشفى الولادة والأطفال في السنتر بالدمام، هو قريب من جميع المراكز الصحية، قريب من يعني easy to go، يعني مكان سهل جدا لوصوله. البلاسنتا أكريتا سبيكترم أو طيف المشيمة الملتصقة هو يعني يعتبر من الحالات التي تؤدي إلى يعني أمراض مزمنة أو مش يعني مضاعفات كثيرة للأم، قد تؤدي في بعض الأحيان إلى الحياة للأم. أنا معلش I will mix between Arabic and English so everybody can understand. The prevalence of placenta previa is approximately 4 to 5 per 1,000 births worldwide. هذه هي نسبة حدوث البلاسنتا الملتصقة 4 إلى 5 إلى كل 1000 ولادة حول العالم. What to do in they found that observational studies from 1970 to 1980s reported a prevalence of placenta previa as approximately 1 in 2,500, 10 to 1 in 400 4,017 cases. More recent data indicates a significant increase in the prevalence in high and middle income countries. The current prevalence of past disorders is estimated to be around 1 in 500. فزي ما انتم شايفين البريفالنس قاعدة تزيد increasing وصلت إلى 0.2% من الولادات، وهذا على مستوى العالم كله. في مستشفى الولادة والأطفال, this is the statistic of our deliveries during the whole year of 2023. We have around 500 deliveries each month. هذه معدل ولاداتنا في السنة. في الشهر تقريبا يعني نوصل إلى 500 ولادة. This is the cesarean rate with the normal deliveries in our hospital during the 2023. As you can see, the rate was still, we are in the range of between 20 to 24, the whole years. Some years, for example, in March, there was a little bit of increase in the cesarean rate, and the others within the normal average between 20 and 24. We established to do a research. بدأنا دراسة في المستشفى. درسنا الحالات in January 2021 to December 2021. أخذنا طبعا كانت big sample, يعني studies it is still going on, not finished yet, but the sample size we took a randomized samples. We took 1,440. أخذنا عينة عشوائية. كانت النمبر of placenta accreta spectrum كانت 23 from this randomized sample. So according to this, the prevalence is 1.59%, and with the rate of 15 to 16 per 1,000. So it is a significant number for us to focus on this issue we have. فزي ما انتم شايفين البرسنتج عندنا عالية بالنسبة لطيف المشيمة الملتصقة، فلذلك ابتدينا ان لازم نضع برنامج عشان نحسن الوضع. Actually, there was a case which was conducted by me on 2020. There was the first case for me. It was she was previous 3CS and diagnosed as percreta early at gestational age of 24. The patient presented with hematuria. And she was diagnosed somewhere else, not in our hospital, as placenta percreta. That was the trigger case for me to focus on this, and it was a challenging case. هذه الحالة أول حالة أنا باشرتها في عام 2020. قبل هذه الحالة كانت كل الحالات احنا نحولها للرياض لأن we don't have a center in our region dealing with such cases. فكانت المريضة هذه ستاف عندنا تعمل عندنا، وكانت عندها مشكلة إنها تروح الرياض لأسباب اجتماعية وشيكانات، وهي ما هي حابة إنها تروح، فهي قالوا سووا لي أي شيء بس I will not go. فكانت هذه التريجر كيس لي صراحة كانت very challenging لأنها صعبة جدا. بالMRI طلع معنا التواس percreta invading reaching the pelvic wall. We admitted her نقولنا على 32 أسبوع. Then we decided to do elective cesarean على 34 أسبوع. عملنا arrangement مع الدمام المركزي أو مركز الدمام الطبي بالقسم المسالك البولية اليورولوجيست. هم عملوا investigations معانا، عقدنا الرنين المغناطيسي، عملنا لها cystoscope مرتين. There was no obvious invasion في البلادر by cystoscope. Then we inserted VGS stent and we did cesarean. It was me and my team, one of my team, she was Dr. Zahra, and our senior consultant, Dr. Wafad Mijan, from really it was يعني كانت من أصعب الحالات اللي ممكن يواجهها أي طبيب. كانت جدا جدا صعبة لأن البلاسنتا كانت طالعة من الرحم وواصلة إلى جدار الحوض. فوين ما تمسك there will be bleeding. There was blood، يعني كنا طبعا جاهزين من ناحية البلد بانك وكذا. there was blood and we proceeded for hysterectomy طبعا. استئصال الرحم بدينا فيه، أعطيناها دم، بس مع ذلك يعني with the difficulty she lost more than 10 liters of blood. There was replacement والحمد لله انتهت على خير. دخلت فترة ICU and she was okay الحمد لله. Her baby is okay and she is continuing working with us الحمد لله في عملها عندنا. صراحة هذه الحالة كانت الحالة اللي حطتها فيني شيء لازم we have to do something. يعني مو كل المرضى they can go and live ويتركون أولادهم ولازم يطلعون من الثامن ويروحون الرياض ويعيشون هناك. يعني it was شيء لامسني شيئا من الإنسانية اللي أنا كطبيبة وعندي مسؤولية لازم I have to do thing for this. كانت عندنا في معوقات لو قدرنا نسميها معوقات. There was some obstacles. There was no clear policy in our hospital. The experience, it was limited experience among our consultants. There was no supportive specialties like urologist, vascular surgeon or GS. And also we have increasing CS rate. لو شفنا هذه المعوقات ابتدينا فيها one by one. اشتغلنا على البوليسي. We did searches, we did meetings and وعملنا our own policies. Regarding the experience, صراحة في some يعني عندنا من consultants they build their experience by attending يعني كانوا يحضرون مؤتمرات زي ما انتم تحضرون زي كذا. كنا متعاونين بحيث ان كل كيس يدخلها اكثر من استشاري في نفس الحاله. عملنا اتصالاتنا واتفاقياتنا مع مستشفى الدمام المركزي اللي يجيبون لنا الدعم من التخصصات الاخرى. بقى عندنا تحدي واحد اللي هو زيادة عدد cesarean rates. كانت it was increasing واحنا قلنا نسوي لها برنامج. وفعلا في خلال هذه السنوات اللي فاتت عملنا حملات توعوية للأطباء وللمجتمع regarding the cesarean rate في محاولة أن نقلل من نسبة حدوث العمليات القيصرية التي لا تكون لها دواعي طبية. So we did campaigns all these years, yearly, to educate the physicians and the public to limit the cesarean for the indicated clinically only. I think there is, as you know, there is a lot of patients coming to you requesting for cesarean for not a good reason. We should not go with this because our path is placenta accreta is a sequence for this cesarean. So nothing is impossible, right? احنا نؤمن ان ما في شيء مستحيل. بدأنا بالمعوقات، حلينا كل المشاكل اللي عندنا. We started to have our own practice center إلى أن وصلنا إحنا نكون referral hospital for our cluster and whole region. يعني إحنا نستقبل حالات مش بس من التجمع الشرقية، بل يعني تعدينا للمنطقة هذه، صرنا يجونا حتى من تجمع الأحساء، من أبريوكا، حتى من الجنوب، حتى من الرياض تريدونا، حتى من الرياض يكون أهلها هنا فشي will come to us. فالحمد لله we became the referral hospital. احنا وافقنا بهذه our Saudi vision، رؤية السعودية للاهتمام برعاية المرأة، فاحنا متوافقين معها في هذه الناحية. وطبعا قدوتنا في الأخير بتكون رسولنا صلى الله عليه وسلم عندما قال استوصوا بالنساء خيرا. فهو هذا هدفنا، احنا نستوصي بالنساء خيرا ونوصلهم في رحلة الحمل إلى الأمان بإذن الله. يعطيكم العافية.
نستمع الآن لكلمة راعي حفلنا رئيس تشغيل مستشفى الولادة والأطفال بالدمام الأستاذ سعد بن محمد الدوسري، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. أسأل الله صباحكم بكل خير. حقيقة أتشرف أن أكون اليوم بينكم في افتتاح هذا المؤتمر الذي وفق الزملاء في قسم النساء والولادة كالعادة في الاستفادة من إقامة المؤتمرات والندوات، بأنها تكون إضافة حقيقية للعمل، تعطي فرصة للمراجعة لما يتم القيام. حقيقة اختيار الموضوع المشيمة النازح، الموضوع يطرح كمؤتمر بين ذوي الاختصاص وأصحاب الخبرة في هذا المجال، يعطي فرصة حقيقة لإعادة المراجعة مع تجربة المستشفى المميزة في هذا الجانب، كما أنه يعطي فرصة أكبر لتبادل المعلومات والمعرفة بين ذوي الاختصاص وأهل الاختصاص في هذا الجانب، ويحدد المعلومات والوقوف على أحدث الدراسات والأبحاث في هذا الجانب. كذلك من أهم الأمور قامت شبكة التواصل والعلاقات المهنية بين أصحاب التخصص، هي بالذات رافد حقيقي للأمور ذوي الاختصاص والتخصص، بما فيه من رفع من المقبولية وسلامة الإجراءات المقبولية، كما أن المؤتمر سينتهي إليه نقل وتبادل المعلومات والمعرفة. أعتقد أن الإضافة تكون يعني قيمة للمشاركين في هذا المؤتمر. حقيقة نترقب بكل اهتمام التوصيات التي سننتهي لها بإذن الله تعالى مع نهاية فعاليات هذا المؤتمر، كما أن الوقوف اليوم على وهو متوقع على أفضل أو أحدث الأبحاث والدراسات التي في هذا المجال. أعتقد أن برضو سيطرح كثير من الأسئلة ستكون محفزة برضو لإقامة العديد من الدراسات البحثية في هذا المجال. شكرا جزيلا لكم جميعا على المشاركة في هذا المجال.
أما الآن مع تكريم المتحدثين بمؤتمر ضيف المشير المنتصر عن عبد القادر سليمان. دكتورة نورة سعيد القحطاني. دكتورة نورة حسني القحطاني. دكتور عبد الله محمد الهويري. دكتورة مريم حمد الخالق. دكتور مفلح إبراهيم عسيري. دكتورة نوال عبد الله الحربي. دكتور مرتضى محمد النبل. دكتورة حميدة أحمد كاظم. دكتورة فاطمة قاسم اليوسف. دكتورة سيما محمد العنوان. دكتورة غادة منصور الدرياني. دكتورة زهرة سعيد الخاطر. دكتورة منيرة ميشو. نتمنى لكم رحلة مليئة بالعلم والمعرفة، والسلام عليكم ورحمة الله وبركاته.
Good morning again. We will be returning back to our lectures. Our next coming presenter is the dynamic personality, Dr. Noura Saeed Al-Qahtani, consultant of obstetrician gynecology, King Saud Medical City Women Hospital. She had her research diploma in King Faisal Specialist Hospital, Riyadh, and aesthetic diploma in Riyadh. Her talk will be very interesting regarding a very challenging topic, scar pregnancy.
السلام عليكم ورحمة الله وبركاته. I'm honored to be here with this marvelous gathering, scientific gathering. My talk, inshallah, it will be short. Cesarean scar pregnancy, single center experience in maternity hospital in King Saud Medical City. سيما ما يجي. This this is a single center experience research. It was done with a group of consultants, me and my senior consultant, Dr. Nawal Al-Harbi, and my associate consultant, Dr. Balqis and Dr. Muhsina. Unfortunately, they are not around. And my senior house officer, Dr. Noor Al-Shartan and Nof, and my specialist ultrasonographer, Dr. Amal Al-Harbi. My talk will be, inshallah, short, so that you will have your break on time, bi'idhnillah ta'ala. Again, it's not work. For the last, I can say for the last 5 years, our experience in maternity hospital in King Saud Medical City, we start to experience high incidence of scar pregnancy with the increasing curve, with the increased number of cesarean delivery. زعلان شكله. So let us go here. I don't know. So what's the definition here? Scar pregnancy is an abnormal implantation of the gestational sac within the myometrium. There is a lot of classification there. One of the classifications have been proposed, especially in 2023, type 1, or what's called on-scar pregnancy, or the endogenous type of scar pregnancy, in which more than 50% of gestational sac will be protruding through the uterine cavity. The other type or definition of scar pregnancy, type 2, or what is called in the niche or in the dehiscence, in which less than 50% of the gestational sac will be protruded through the uterine cavity, and most of the placental trophoblast will be invaded through the dehiscence and inside this cavity, or what's called the niche. And this is the most high risk, type 2, which can be precursor to the placental accretal spectrum. If you look to the incidence, what is the true incidence of a scar pregnancy? Unfortunately, there is no true incidence regarding a scar pregnancy, but the most acceptable one, it is happening 1 in every 2,000 of delivery, and almost 6% of the whole ectopic pregnancy. What is the differential diagnosis? If you look at the scar pregnancy, ultrasonographer during the first trimester ultrasound, and she's looking for this gestational sac impending in the lower segment. Differential diagnosis should, maybe it's a missed abortion, any kind of abortion, or low-lying gestation, or another cervical ectopic pregnancy. Okay. Excellent. What is the risk factor for scar pregnancy? There is a lot of risk factors, as mentioned before: repetitive scar delivery, adenomyosis, in vitro fertilization, repetitive DNC, and also repetitive manual removal of the placenta. I would like to add also one factor regarding risk factor. This is poor repair of the cesarean section. The technique itself, it can propose to this kind of scar pregnancy. Presentation. About 1/3 of the patient can be presented asymptomatic, totally asymptomatic, during the first, for example, 6-week first ultrasound for viability. With expert ultrasonographer, she can pick asymptomatic scar pregnancy. And the less of the percentage patient can be presented by mild BV bleeding to horrible, catastrophic BV bleeding, reaching to hypovolemic shock or uterine rupture and the end hysterectomy. Scar pregnancy is thought to be by some, and one of them, it is the precursor for placental accretal spectrum. I have been reading for the last 5 years a lot of articles, and what I found, scientific literature describe mainly case reports, only cases reports. So given this small number of patients have been managed, it's very difficult to define which is the best clinical practice to manage such cases. Our aim of the study, just to highlight the characteristic, diagnosis, and the type of management of scar pregnancy at tertiary obstetric hospital in Riyadh. It is cross-sectional study, and it was conducted in tertiary referred hospital, King Saud Medical City Maternity Hospital, between the years of 2017 January till 2023, the last year. And almost we collected 28 patients over the 5 years period. Analysis was performed considering the medical record of our ultrasonographer units, and the diagnosis was performed by transvaginal ultrasound with this criteria. The whole criteria, this one to describe by ultrasound, transvaginal ultrasound, it should be there, all of this criteria to diagnose scar pregnancy. So we will have an empty, there should be an empty gestation, empty uterine cavity, empty cervical canal, so that we will exclude cervical pregnancy. The presence of gestational sac with or without fetal cardiac activity, exactly above the internal uterine isthmus. Absence or thinning of the myometrium, which has covered the gestational sac, and also functional, there will be functional placental circulation surrounding the gestational sac. All the diagnoses have been done by at least 2 experts, gynecologists, ultrasonographer, just to ensure we reach the diagnosis. Very interesting here slide. I took it from upon the permission of our specialist, Dr. Amal Harbi, ultrasound. As you see, one of our patients, we can see this is a transvaginal 3D ultrasound view of uterus in sagittal plan showing cesarean scar ectopic pregnancy, as in blue arrows. Very interesting. The myometrium thickness almost is 3 millimeter. Another interesting slide, as you see here. Empty uterine cavity, empty cervical canal to exclude cervical pregnancy, and the thinning of the myometrium here, maybe it's 3 millimeter or 2.5 millimeter covering gestational sac. Another interesting view in the diagnosis of scar pregnancy, here demonstrating a gestational sac with the fetal blue and the blue arrows, as you can see, and also thinning of the myometrium with the red, I can say this is the red arrows, about 2 millimeter. So what is the sample characteristic? So we have 28 patients we collected. Among them, 22 patients have been managed only medically, and the 6 of the patients, they used to have an expected management. The one who choose to have an expected management, their baseline beta ECG was around 1,000 to 1,000 to 200 to 2,000 international units. And all patients, the one who choose expected management, we notice, we read in the file, they have hemodynamically, they are stable, and we follow them by beta ECG and transvaginal ultrasound. Regarding our patient, 22 patients who have been managed medically by methotrexate, if you look at the sample characteristic, maternal age was 37 years of age, gestational age 7 weeks, and most of them have been diagnosed by ultrasound on almost 51%. And the basal beta ECG, the median basal beta ECG was 7,923. This graph, it will shows the distribution here. It will highlight the prevalence of the cesarean delivery among the patients. And the most of the patients, almost 40% of the patients, they have previous one cesarean delivery. And almost 25% they have three previous cesarean delivery. And the rest, as you see, 3 and 4, they have previous multiple cesarean delivery. Again, the relation, the association, we will, inshallah, tomorrow we will discuss this and we will debate with Dr. Maryam regarding the true relation, the hierarchy between cesarean delivery and the scar pregnancy and the future pregnancy. Regarding the methotrexate dose, almost 37% of the patients, they receive single dose methotrexate, and almost 27% of the patients, they have more 2 doses, and small number of patients, they receive multiple doses of systemic methotrexate. In all, about 6% and 6.9%. So most of our patients, they receive single dose methotrexate. Relationship between the previous multiple cesarean delivery with the incidence of scar pregnancy. In this graph, or in this table graph, it shows methotrexate dose, the methotrexate dose and the relation. And most of our patients, they receive single dose, not multiple, and about 40%. And another percentage, almost 30%, they receive 2 doses of methotrexate. And a small number, they receive multiple doses, either they receive 3 or 4 and 6%. If you look at the mode of delivery, most of our patients, they receive systemic methotrexate in about 44%. And local, they receive only 13%, and both, they receive systemic and local administration and almost 20%. This table will show distinguishing between sample characteristic and the fetal heart status. We notice that from our calculation, the patient receiving more than 1 dose have higher positive predictive value, almost 72%, compared to those who having only 1 single dose. In type of management approach, we noticed that the patient who didn't respond very well to initial systemic methotrexate, they respond very well with the local methotrexate with high positive predictive value. سيما again معلي اعتذر والله تعبان عليه لسنة لأنه كله جراف دكتورة عرفته
هل هو باين عندك؟
لا كله جراف لا ما هو باين حتى على كل حال the last graph يعني ما يعطيني محاضرتي
ذيك الدليفري ودي السيزيريان سيكشن طبعا كبيرة منها
والله يعني اوكي ايه So this graph.
Let me try. See.
Okay, أنا بتكلم.
Okay.
Go ahead. Go ahead.
لا, it's graph. It's a graph. It's supposed to be. It's a graph. Says okay. The other graph showing the differences in methotrexate, the mode of administration and the number with the normalization of the beta SCG. And it shows there is no significance. There is no significant differences in the outcome between the number methotrexate dose and the mode of administration with the normalization of the beta SCG. On the other hand, we notice the most important factor in the fetal heart rate activity. Yes. الله يسعدك. خليكي جنبي. نعتذر يعني في حاجة.
معلش. No problem إن شاء الله.
So this graph, and I love this graph. It's the differences in methotrexate dose number of dose, and the mode of administration with the normalization of the beta-HCG. And we notice there is no much difference with the p-value regarding the number of doses of methotrexate and the mode of administration with the normalization of the beta-HCG. But we notice at the end, the most important factor, the theta heart rate activity with a high positive predictive value. Yes. So our discussion here, cesarean scar pregnancy treatment, it should be tailored to the individualized patient. And treatment should be targeted upon the patient's stability and upon gestational age and the size and also the desire for the future fertility. Yes, please. One very interesting study has been done last year, 2023. It's the first trimester cesarean scar pregnancy. It's a comparative study analysis of treatment option from the international registry. Upon that, they allocated 400 patients, and the treatment option was differ between suction curettage with or without double balloon catheter. And this is this is the first optional recommended treatment. A second option, in percentage, it was by resection of the niche, either hysteroscopic or by laparoscopic, and they didn't recommend at all medical treatment or expectant treatment in the management of scar pregnancy. Their explanation, due to high complication of the methotrexates, benzodiazepine or nephrotoxicity, and prolonged follow-up of the patient just to normalize beta-HCG. In our study, we found 22 patients of the 28 patients received methotrexates. And all of them, they respond very well, except one patient. They give her adjuvant in the form uterine artery embolization just to normalize beta-HCG. And beta-HCG for this patient was almost 10,000, and it took almost 40 weeks just to normalize. So, but treatment of scar pregnancy with a serum beta-HCG more than 5,000 international units, or the presence of cardiac activity, often require long period for follow-up the patients, and also it needs multiple doses, and it needs also adjuvant, another type of treatment, such as uterine artery embolization. So the current study, our current study, and also the previous literature, they have shown that unsuccessful systemic methotrexate was followed by effective local methotrexate, and that local methotrexate may have a better embryocidal effect than the systemic methotrexate. Yes, please. So our conclusion. The number of cases of scar pregnancy have been increased for the last decade, I can say, with the increasing curve of cesarean delivery. Early diagnosis with high clinical suspicion and an expert diagnosis we can manage and we can pick up early at 6 weeks. The management, it remains challenge and dilemma. We recommend individualize each patient's management taking into account the type of scar pregnancy, fertility concern, and the presence of expertise. With appropriate selection of cases, scar pregnancy can be managed with methotrexate treatments only. But again, prospective multi-center randomized control study, it should be there just to have a guideline regarding the management. In our case, because it is retrospective, most of our patients, we couldn't follow them just for the outcome later on and the fertility issue. Also, our patients not managed according to the type 1 or type 2. And because of this single center experience, we couldn't compare other type of management, such as suction curettage or other invasive procedure, just as repair and resection. Thank you very much.
Sorry,
Diana, sorry. I can say every 6 months like that. But nowadays, I can tell in our center, every week, not only the first trimester, the last week or maybe last 2 weeks, we have patients in 14 week, and this is more dangerous. And one case had been opened by Dr. Nawal Al-Harbi, our senior consultant. Almost she was 16 week or... Yes, we had picture and it was ballooning.
Should we report that?
Yes, we are reporting. It was ballooning and Dr. Nawal, she resected the whole niche. Dr. Balwood, urologist. So, why I try to propose this as research? Because increased number. And not only that, now with this big study, the one published, the big registry, they advocate against medical management. They advocate against expected management. Our 6 patients, the one not managed, their follow-up, we follow up in the ultrasound in their record and found that they aborted spontaneously. Keep in mind, the patient consented very well. Keep in mind, the patient hemodynamic is stable, and keep in mind, the patient aware what's going on. One report, I read it, the patient was diagnosed as 6 week, and it was type 2, scar pregnancy, 6 week. And patient refused any type of management. And they proposed for her all these kind of complication. Bertrita was there. They kept her inpatient till she reached 30 week. And diagnosed Bertrita and hysterectomy was done at 30 week. So, why I propose this article? I'm telling there is a role, there is a place of medical management, there is a role of expected management. And not all center will have all these expertise who can manage by hysteroscopy repair of the niche, laparoscopy repair of the niche, still place for medical and expected management. Thank you very much.
Thank you, Dr. Noura. Regarding expected management, did you follow this patient? They will continue their pregnancy or...
Yes. This is...
Or they have spontaneous abortion?
Yeah. Actually, our concern, this research, just our management. We didn't focus on the outcome. This is inshallah because most of our patients, we lost them. Most of our patients outside Riyadh, and we lost contact them. Some of them, I tried to contact them, but they refused to cooperate, this kind of dilemma.
You don't know if they follow
The outcome, this is
they
another research. This is another research I'm proposing. What is the outcome fertility with this medical management or expected management? Just we follow them in the clinic and their pregnancy result. But that's all by beta SCG and transvaginal ultrasound. Regarding the fertility outcome, we didn't follow them, unfortunately.
Okay, regarding medical and surgical management,
Yes.
do you think the medical is superior?
Our research.
In general,
لا لا.
do you think it is superior to reduce the complication of surgical bleeding and...
No, our research is only to focus on the medical management.
No,
We didn't compare.
In general.
Yeah, in general, yes. In general, if you read this article, it's published soon in August 2023, and they compare all type of managements. But that article is a big center, and no, it's almost 400 patients, and they allocated from almost 30 center. Okay, but still going on. But there is no guideline, regarding how much this one, the percentage of success compared.
Thank you.
I can answer your question.
تفضلي دكتورة.
The patient who came with bleeding, Dr. Noura cases, the asymptomatic patient, stable patient. But we had patients who came with bleeding and severe bleeding. We opened them, and they have a very big bulge in the abdomen and scar, almost a scar dehiscence, like scar dehiscence. I had picture, if we can show you later on about this case. They came with bleeding, so we have to take them from ER to OR.
Yeah, Dr. Nawab, she's telling any comparative, in general.
In the stable patients, this is like...
Yeah, the stable patient, the last registry, the big article, the collaborative registry, they are advocate with suction curettage and double balloon. About success rate, according to them, it's almost 93%. And second option, resection of the niche, okay, an almost comparative percentage, high comparative. But they advocate against medical management. Even the success rate with them, it was almost 83%. But they face complication with the methotrexate, bencytopenia and nephrotoxic or something like this.
I have a question regarding the patient. When you decide from expected management to be shifted to the medical management?
No, you know, this is a retrospective. This is a retrospective study. You know, we didn't choose. We are collecting these files, okay, and we study each case. Okay, we
So
didn't
you don't
choose,
have-
but we تفضلي.
Yeah, you don't have a special protocol regarding the patient. She was on
In our hospital, in our hospital we have protocol.
Okay.
You know, the main thing, stability of the patient, patient consented, okay, the patient in hospital, and we are following the patient will be in hospital, and we are following the patient by beta SCG and transvaginal ultrasound. Okay, there is till now, Doctora, there is no true guideline regarding who to choose for expected and who to choose. This is all it's just a retrospective study. But as I told you, in the recent I will published, they don't advocate at all about expected management for the treatment of scar pregnancy. But our experience in maternity hospital, there is a rule. There is a rule. Thank you all.
Our next speaker is Dr. Abdullah Muhammad Mughir, interventional radiologist at King Fahd Specialist Hospital in Dammam. He will be presenting to us the role of interventional radiology in placenta accreta spectrum. تفضل دكتور. If you will kindly put on this.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Mr. Chairman, Dr. May, and the scientific committee for inviting me to give this lecture. And it's not only to give this lecture, it's also to be part of the team. And we are, as an interventional radiology department in King Fahd Specialist Hospital, we are more than happy to be part of the team and to help our team in MCH for any time. So I will talk about the role of IR in placenta accreta spectrum. As an introduction, which is already was very clear by the previous presenters here, we have three types of abnormal placentation, and it's depend on how much placenta it goes across the myometrium, either within the myometrium or crossing to the surrounding tissue. And as we all know, it's life-threatening condition with a high average of blood loss. Maternal mortality reported to be 7%, and 90% of patients require blood transfusion with all the complications of blood transfusion. Pathogenesis, it's still the exact pathogenesis, it's unknown. However, as mentioned before, any previous instrumentation, this is the main and clear mechanism of developing abnormal placentation. The risk factors, again, it's cesarean sections and presence of placenta previa, which is there is an association between the placenta previa and the abnormal placentation about 90%, and these two is the major risk factors being reported in the literatures. Also, previous placenta accreta, advanced maternal age, or presence of submucous leiomyoma, all of this considered as a risk factors. As mentioned by Dr. May and others, the incidence is increasing. In 1980, it was about 1 case to 4,000 births, but nowadays it's one case per almost 300 or 250 case. And it's reported clearly that when increasing the number of cesarean section, the percentage of abnormal presentation will increase. The diagnosis, it's the most important factor and affecting the outcome in prenatal is the prenatal diagnosis. Because if we reach to the diagnosis early, will make us make the clear delivery plan, make the procedure elective rather than going for an emergency, and also give the team to go for multidisciplinary team approach. Management, as you all know, it's either the standard is going for cesarean hysterectomy, or if the patient has strong desire to preserve the fertility, then we'll go for uterine sparing technique. There is a lot of techniques reported for uterine sparing technique. However, as IR, we'll talk more about the balloon occlusion as an elective case or uterine artery embolization if it is an emergency case. So the role is to reduce and control the intraoperative bleeding. That's the main role of IR. And reduce the blood loss. And before the procedure, we explain to the patient clearly that our main aim is to reduce the blood loss and save the patient life, not to save the uterus. This is very clear. So by reducing the blood loss, it's a life-saving, and it would reduce the blood transfusion rate, and it will make the surgical field more drier for the surgeon, and that might help to assess preserving the fertility. Techniques, we have a lot of techniques being reported. And again, as I mentioned, if it is an elective, then we have either balloon occlusion in the internal iliac, which is the most common technique in the practice, or in the uterine arteries. Also, occlusion balloon in the aorta, or the common iliac artery. As an emergency, it will be considered as a case of postpartum hemorrhage, and we will go for uterine artery embolization using the particles. So what's the advantage of common iliac artery versus internal iliac artery balloon occlusion? It's easier to place the balloon. It's less fluoroscopy time and also contrast media given to the patient. It will overcome the collaterals from the external iliac and femoral arteries, less hemorrhagic during the procedure, with main blood loss reported is about 1.5 liters. The disadvantage of common iliac artery is the complication rate, thrombosis or embolism of lower limbs, as reported in the literature. Aortic balloon, it's even superior. It's short. It will make the procedure time shorter, and it's very easy to place it in compared to common iliac and internal iliac, and also to control the collaterals like median sacral artery or lower limb, lumbar arteries or inferior mesenteric arteries. My own technique that's been used, it's to do it, we have two types of technique here. Either we do it in hybrid room in OR, which is not available in our center, or we do it in angio room and then we transfer the patient to the OR. Usually we use urinary catheter or Foley's catheter to avoid presence of contrast in the urinary bladder, and that will obscure the field. Usually we go puncturing using 6 French sheath through the right common femoral artery, and we make sure always that we have flushing system with heparinized saline, and we need to select the proper balloon size, and we need to test the balloon size by an inflation inflation this balloon to make sure we are not oversized or undersized. And once we make the test, we deflate the balloon and secure before transferring the patient to OR. In fact, transferring patient from NGU to OR, this is the main critical time. And I usually, myself, I go with the patient from the NGU table until the OR table, because this is the time that nursing or the technologists, they are transferring the patient. They might, by mistake, just dislodge the catheters and balloon from its site. So we make sure that we have radiolucent operating table in the OR, and we start inflating the balloon after delivering the baby, and also after clamping the umbilical cord, usually intermittent inflation. For internal iliac artery, I usually go for 20 to 30 minutes, and then with deflation every, I keep 1 or 2 minutes to deflate. And then once the operation done, we remove the balloon, but we keep the sheath till next day for any emergency bleeding at night. So what about the literature review? There is a lot of debate about using a balloon to help in the placenta accreta spectrum. Some of them, they said there is a benefit of using the balloon, and others, they mention or they clearly say there is no benefit. This is one example of recent study. They clearly said they did not reduce the postpartum hemorrhage or have any effect on maternal or neonatal morbidity. But again, this study is talking about the internal iliac artery alone and not talking about the balloon in the aorta or the balloon in the common iliac artery. And as we mentioned, by including the common iliac artery or the aorta, we will control the collaterals more for the patient. This is another study. It's talking about how effective is the prophylactic internal iliac artery. And as we can see here, this is the study group, and this is the control or surgical group, and this is the balloon group. If you can see the amount of intraoperative blood loss, comparing between the balloon and non-balloon group, and also in terms of blood loss within the postoperative 24 hours, as well as the transfusion rate, we can see it's clinically as well as statistically preferring using the balloon. Again, here another study talking about how much effective the internal iliac artery balloon, occluding balloon, in case of placenta accreta. And again, if you can compare here the estimated blood loss as well as the transfusion rate, it's almost 50% less with the balloon group in comparison to the surgical group, which is clinically as well as statistically it's significant. Another study, showing that case of blood transfusion, it's more in the more in the surgical group in comparison to the balloon group. Again, this study, it's showing the outcome in the all spectrum and the outcome and comparison between placenta accreta and increta. And here, what about the result when it is placenta percreta itself? And we can see here the difference between the balloon group and the surgical group. It's very significant clinically as well as statistically, with no complication were related to the use of endovascular catheter noted in this study. No maternal or fetal mortality were reported. No acute fetal abnormality has been reported as well. The average fluoroscopy time was only 3 minutes, and fetal radiation exposure was about 3 to 6 rad, which is very low. And failure of internal iliac balloon occlusion could be due to extensive collateral from other arteries. This is another study showing the balloon in the aorta itself. If you can see here, it's 230 case goes for balloon in comparison to 38 case goes for surgical. And the blood loss, it's about 900 ml in comparison to 2,800 ml in the surgical group. Again, blood transfusion, it's almost 400 in comparison to 1,600 in the surgical group. Again, hysterectomy, there is no hysterectomy reported in the balloon group in comparison to 3 cases in the surgical group. This is again another systemic review and meta-analysis. It's about 11 studies from 2012 to 2018 with a total of 730 patients, comparing between using a balloon in the aorta and surgical group. And this is in terms of blood loss. We can see the study going favoring the balloon group. Also, blood transfusion, it's also favoring the balloon group in comparison to the surgical group. And also in terms of hysterectomy rate, it's favoring the balloon group in comparison to surgical group alone. Also, operating time, it was less with balloon group in comparison to the surgical group, as well as post-operative hospitalization duration. Another retrospective cohort study, and this is comparing surgical and balloon, and also comparing between each and every location of the balloon, between internal iliac, common iliac, as well as the infrarenal abdominal aorta. And this is the estimated blood loss. We can see it's higher with the surgical group in comparison to the balloon. And also blood transfusion, it's very high in a surgical group in comparison to the balloon group. And this is when they divided into by the location of the balloon. We can see that the blood loss is higher in the internal iliac in comparison to the common iliac, and in comparison into the infrarenal aortic occlusion balloon, which is less. And the same goes to the blood transfusion rate. Again, this is comparison in general between the surgical group and balloon group. And you can see the operation time is less in balloon group in comparison to surgical group. Hysterectomy rate is less in balloon group in comparison to control group. And also the need for ICU admission, as well as the length of stay in the hospital, which is clinically and statistically different. Again, here we can see the clinical finding based on the location of the balloon itself. And we can see the operation time, it's much better when it's in the aorta in compared to the internal iliac or common iliac. Hysterectomy rate also the same, and need for ICU admission, as well as the length of post-operative hospital stay, it's more significant when the balloon used in the aorta itself. Again, this is the last systemic review and meta-analysis showing, preferring about 15 study with about 1,000 case, and showing clearly that this systemic review and meta-analysis showing preference or going for favoring the balloon group in comparison to the surgical group alone. This is my own data. I did it from January 2012 until December 2014 when I was working in the South in Asir Central Hospital. And I collected this 6 cases. And if you can see here, I used the approach internal iliac artery balloon occlusion. And the balloon size was between 6 and 7 mm. These 4 cases goes for, we managed to preserve the uterus. And if you can see here also, the blood loss was controlled as much as we can. And also the blood transfusion was very controlled here. Except this, the last 2 patients. The last 2 patients, in fact here, there was 2 major factors. This 4 cases was done by the same IR and same surgeons. But this case, the surgeons was different, and unfortunately, when we reached to 3,000 ml of blood loss, she decided to go for hysterectomy. Sorry?
Wise decision.
And then the last case, patient refused the balloon occlusion technique, and she just decided to go for hysterectomy. And if you can see here how much of blood being lost, is about 12 liter in intra-op, and but luckily she survived. In conclusion, prophylactic balloon occlusion is safe and effective and can help to avoid hysterectomy. However, still more randomized control studies are required. Thank you very much.
Thank you so much, Dr. Marie. Any questions?
Thank you for your presentation. It was very concise and helpful. My question regarding the iliac ballooning. Now, you showed very beautifully the conflicting evidence regarding the efficacy of this approach. We know that there is no real strong evidence showing that it will reduce morbidity and mortality. So, in the view of this questionable efficacy, do you think that there are long-term or short-term adverse effect of this approach on the mother?
It's being reported that the most complications or adverse events happen to the patient. It's showering thrombus or ischemia, yes. But as I mentioned, I never seen this in the few cases that I have done it. The most complication when we go in occluding the common iliac artery and aorta. But to me, it's less when we go for internal iliac. Now, we need to control, it's many factors. We need to control, because what happened in some studies that been reported this ischemia or showering thrombus, and I have met some of interventionalists. They will just do the procedure in the angio suite, and then they will send the patient with the balloon to the OBGYN surgeon, or sending, fellow or resident to control the balloon, which is, I totally disagree with this. You need to go yourself. And as I mentioned in the presentation, it's very critical time when you move patient from the angio table to the OR table, because you might dislodge the balloon, and if you, in the OR, the situation, I don't know whether some of you has done the balloon occlusion or contribute in cases like this with the IR. The situation in OR, it's totally different. You just have a CR, and sometimes you cannot just push the CR while the operator doing. You just blindly inflate or deflate, or if you have to inject gel foam, just blindly. This is not an appropriate technique. You have to go. You have to bring the CR. You need to make sure before you inflate while the patient on the OR table. Make sure you're still in situ and you are ready. Then you go ahead.
Thank you.
Any other questions?
Assalamu alaikum, Dr. Hamid. We had the experience in National Guard Riyadh a long time ago when I was a resident that we have patients coming with the balloons. I'm an anesthesiologist, by the way, consultant anesthesiologist, but my experience in residency was all National Guard Riyadh. And we had those patients coming from the radiology suite with their balloons non-inflated, and it will be under control, and it has a policy, of course. And it has Sorry, my mistake. Anyways, we are the anesthesiologist along with the obstetric surgeon who decided to inflate or deflate the balloon intraoperatively.
Who is deciding?
The surgeon with the anesthesiologist.
That's what I'm saying. This is wrong practice.
Anyways, that was a long time ago. My question is, what is the maximum time? Because you said that we would inflate for 20 to 30 minutes, and then we would deflate just to decrease the risk of ischemia and all thromboembolic events intraoperatively. But again, you have the upper limit, at which point you would maybe discuss with the surgeon or whoever and the responsible of the patient. It's just I will not get the surgeon to work for 6 hours or a patient who is ischemic below. So do you have a ceiling or a recommended duration to inflate the balloon intraoperatively? And you will also contribute with the surgeon, with all the team regarding just abrupt and go forward and just save the rest of the body of the patient?
That's a good question. It's depend the time or the duration of balloon inflation. It's depend on the location of balloon. Internally it's forgiven in comparison to common iliac and aorta itself. So that's why I go for longer time, 20 to 30 minutes. In the common iliac or aorta, you have to reduce it, like a 5 to 10 minutes maximum, and then you deflate. For sure, again, what you mentioned, that the surgeon themselves or the anesthesia, they will inflate or deflate the balloon. This is to me wrong practice, and that's why a lot of reported complication is because of this. You have to correlate and you have to talk shoulder to the surgeon who is operating the patient. And you have to ask him, is this good? Because sometimes you'll say, I'm fine, I'm controlling the bleeding. So the surgical feed looks like drier. If not, then you can react. You can inject the gel foam sometimes or something to help and support. But it's a really not an easy procedure, because you have to work again shoulder to shoulder, and I always stay with the surgeon until he finishes this. I never leave.
Again, what's the maximum time? Would you go 6 hours or maybe?
Sorry, it's an intermittent. It must be intermittent. You cannot occlude it for. You cannot. For sure, if you occlude it for 6 minutes, say 6 hours, then things is gone. You have to, like 5 minutes, and then you deflate. And you inform the surgeon, I'm deflating. And he will tell you, or she will tell you, yeah, now the bleeding is more. So you give him like one minute, and then you inflate the balloon again. Yes, Dr.
Question. Is there any familiar with any comparative study between operative internal artery ligation with the common iliac balloon? So there is any comparison study between these two techniques, or you try an artery ligation intraoperative by the surgeon comparing to the intervention?
I haven't come across something like this, but when you think about the mechanism, it's almost the same, with one more advantage for presence of the balloon there, because you can deflate, inflate. That's number one, and you can use that balloon catheter to inject gel foam to control in case that bleeding not stop. That's a two, for me, advantage in comparison to ligation. Awesome. Any more questions? Okay, thank you very much.
Warahmatullahi wabarakatuh. Welcome back. Hopefully you have been rested and you had the time to have your lunch and do your prayers. We'll resume our symposium. We had pushed one of our morning lectures to the afternoon. So we will be starting with Dr. Maryam Hamad Al-Khaldi, consultant obstetrics and gynecologist in the National Guard Hospital in Al-Ahsa. Her crucial talk will be including the preparative of placenta accreta spectrum patients. Please, دكتورة تفضلي.
شلون تحط كذا؟
حط لك حاضر. الاب اند داون شيكت عليه شغاله يعني السلايد.
ان شاء الله. اوكي ماشي. Are you sure you want to listen or you want to sleep? Tell me, either I can be at your comfort. Allah, I call it sleeping lecture. ما أدري ليه. See, anyway, it's a sweet, very brief one. Honestly, I don't like to give lectures. And I believe after the first 5 minutes of any lecture, I go to sleep. So I hope I don't bring you to sleep with me. Okay? Inshallah. I like the lecture to be very brief, concise. Most of it comes from our experience. Especially this talk is very important as I see it. Just bearing in mind having my experience in the medico-legal aspect, being a senior consultant in this place, humbly. So let's bear it with me. When Dr. May gave me the talk, I started really to do so many readings. Oh God, I read a lot. And then I said, I will really not bother you with any of these things that I read. I know that you can read it and you can find it anywhere. But let me just give you, and it's just a small piece of me, if you could pair it with me. And having or looking at the placenta accreta spectrum from other aspect, let's say how we handle it when it comes to us. So whenever a patient comes to you, a patient is diagnosed, let's say, as early as 18 weeks or as early as mid-trimester diagnosis. So our approach has to be very careful. I've been involved in the medical legal for more than 8 years. I've been there in the courts and going with our colleagues for so many prolonged things. So I said, let me just hand it from this way. If I could just give them a piece of it to just help them how to handle it. I would say placenta previa is a terror. It's a real terror for us. It's not here just to give you the aspect of just the diagnosis. But once you got your patient as early as mid-trimester, diagnosis of just a placenta previa, we haven't got to the pass yet. So now the journey will start of what is it? Is it just a previa? Is it just a previa or it's also an accreta? In either case, the handling of the patient has to be very, very, very careful. Why? In the courts, who usually claim the money? The husband. Who usually put you in trouble? The husband. And you gave him very good excuse to get the money and get another wife. So you better be ready for this. Oh yeah, okay? So this is what I'm telling you, that I will not just take it like a regular lecture that anybody could listen to it. But we should be really careful in our approach, that how we handle it, how we, let's say, embrace it. Okay? So, one of the worst diagnoses for us as an obstetrician is what? Placenta previa and ectopic.
They are the two diagnoses who put us on our toes most of the time until we got relieved. So we'll just handle one of it. It's very important for you to know how to approach it. What do we call it? Risk assessment. And then we will go for the risk management. I will handle with you the risk assessment point. Risk assessment has so many pillars. How to do or how to approach it in risk assessment. And this is what we really need to go through it. Very careful, very careful, very careful. So when you go to do the risk assessment, what do we mean? To assess a patient, to have so many communication, let's say channels. The most important communication channels, is it with the doctors? No, it's with the patient and his beloved one. So when you come to approach it, you got the diagnosis. Now let's think how we will handle it. So, unfortunately, our training program, if you have any RTB here, we have noticed something which is really, it makes us feeling very pity about it. That the communication skill from generation to generation, it's really declining regarding the aspect of the resident toward the patients. That's why it's very important to teach him how to, until now, if there is any breaking bad news, for instance, I will tell you about one scenario of the patient. Yalla, start, lend me a time now, story time. So what happened? We did the laparoscopy and we did the hysteroscopy. That patient had, I'm just telling you this example. That patient had a matted cavity, hysteroscopy, we couldn't, for a while we thought we enter into a false passage in the hysteroscope. And in the laparoscopy, bilateral tubal ligation, bilateral tubal blockage. So the resident, she's a senior. She came to me and she said, we can't discharge her today. I told her, for God's sake, how you will discharge a patient with this diagnosis and tell her, listen, you have a matted uterus and you have bilateral blocked tubes. I told her, breaking bad news for a patient, you cannot just do it as such. You have really to initiate yourself. And I will tell you tomorrow how we will do it. Let's call it a day, okay? Let's finish our list. And then I need you to come with me tomorrow to see how we do breaking bad news for the patient. Until this time, not all, and actually sometimes even when they are senior resident, the junior, they learn it very fast. If they have somebody senior who is accompanying them all the time and tell them that what you should do, level patient to doctors, do this, have pause, give her the fact, get a pause, make sure that she understood all the things. And what I will advise, that every tertiary hospital or a secondary hospital, they should have what is called, in Canada and North America, it's all the same. They have what is called a family room. Do you know what is a family room? It's like a counseling room. So when you make sure that when you break a bad news, you make sure that the patient doesn't have 3 patients with her. بعدين البيشنت تقول والله خليتيني محتوى يا دكتورة. For sure خليتها محتوى. طيب؟ So you have to be careful when we come to do the breaking bad news and make sure that you don't double yourself because it's really overexerting and so confusing. Why is that? Sometimes you'll be as lucky as when she has her companion with her and you will break the bad news and you will end up with her. But the problem is what? The problem is that she will think that you are terrifying the patient, terrifying her, calling her husband. Her husband will come with all his arms and power just to tell me why you told my wife like that. That's why I really recommend to have something called a family room, or let's say it doesn't have to have this name. Actually, it's a counseling room. Even this room, you needed to counsel her because most of our RTB will claim that we don't have place to counsel our resident, which is something very important. So please, let's have in any place that we have a counseling room. بدأ يخربط هذا الحين لسه تونا طيب who should do the counseling? Would you leave it for R1? 2, 3, 4, 5, junior resident, junior consultant, senior. No. The consultant in charge should be as serious as such. Don't you think that? Listen, I will tell you something. Call the patient before she calls you. Let's call the patient, sit with her before she calls you, and she will let you sit, then she will give you a hot shower, she and her husband. So it's very important, and don't do it alone. Why? You better, when you do the counseling, with your communication skill, to have a team with you. It is two things, by the way. Sometimes you just need somebody with you in the room who's just nodding until these guys, look, just listen to what she is saying, nodding. And other thing, they should be also a witness with you. Because after you finish all this counseling, they will just go when it comes for a complaint and they will tell you nothing was done. So, and it's better when you come to do it, the documentation, please, documentation. I will just say documentation until you feel bored with me. Why? Because when things happen, we don't look at people. We look at documentations. So if you have done it, document it, it has been done. If you have done it and you didn't document it, nothing will help you. It's only your say against these people. So just be careful to teach our juniors the importance of documentation. Documentation is very important. I believe most of the people here in this room is really senior, but you really need to convey this message. Documentation is really important. So many cases I go to the court with it, nothing, I will finish it just in half an hour. If there is a documentation, that's it, case closed. Because they will come in a complete denial and I will tell them, لا والله مكتوب, it's written there. لا يا دكتور, it's written there. دكتورة كتبت هنا وكتبت هنا وكتبت هنا وكتبت هنا وكتبت هنا. He will still in a denial, but the sheikh will listen to me. He will know that it has been documented. So case is closed. That's it. So documentation is very important. Make sure it doesn't have it with the patient herself. Make sure if you could put it in a counseling room, separate and concealed. And make sure to have eye and eye contact. And make sure before you leave the room that they fully understand it. And make sure before you leave the room, tell them we will write it. All our agreement with you, we will write it. So it's a full counsel regarding the patient. One of the very important things, especially with the husband there, and if you could get even the signature of the husband, is your approach for that patient according to the diagnosis. If it is just a previa, that will be another also consent. But you have to tell them also, we might need other specialty to be with us in this. Let them think that it's not you are the one-man show. Placenta previa or accreta is not a one-man show. It's a collaborative efforts. God help us with it. So it's very important in your approach that you tackle each and everything. Okay, well, doctor, I did this thing, but I forget it. No, if the patient is admitted or even she is another one, make sure that whatever you miss, you document it. We look at all the documentation. So try not to miss anything with this documentation. Documentation, please. Documentation, it saves you and it shows that you really care. Even if the documentation, it will happen by the resident and you or your senior registrar. So make sure your senior registrar, she is not that hero that telling them that this is what's happening. Please let them make sure that in this one of these visits then seen by, I will really appreciate it if every time you make your visit and it's written seen by. Just people, show your face, hi, how are you? Nothing new, and just to make sure. Sometimes there will be some of the misinformation that patient will not be care to give it to somebody else but you. So just make sure if the patient is admitted, you just be often say hi from time to time. We know you are very busy. And by the way, if you see her, she will تحفظ لك جدول الأكاديميك ومتى عيادات ومتى OR ومتى مدري وشو. She will know your schedule. So you can tell her that tomorrow I have OR, I might not be able to come to you. Somebody else will come to you. You see how careful you are with this one? And make sure that your resident also document these things. So please make sure documentation is very, 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 very important. That communication with the patient finish. You don't have to call your other teams, because some of the doctors, consultant, I don't know why they insist that to call the neonatologist. You know, in the Western country, they do that. I know this. But it's not very practical in our situation. So it's enough for you to do this multidisciplinary team meeting and convey the message to the patient. And please, documentation, 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 please. So when you do this one, you make sure that you did the documentation, that we documented that we meet with so and so and so. Sometimes the most important, because she's as a mother, whom she wants to see? The neonatologist. So this is usually who is of big concern for the mother and the father as well. The surgical things and all other aspects, it's really, it is something. But sometimes they need some reassurance from the neonatologist and your approach for them. So who should be in this multidisciplinary approach? Dr. May mentioned, I'm very happy with your lecture. I mean, you really saved all the talk that I want to say. Your experience in this aspect and putting this as, let's say, a pillar in approaching placenta accreta spectrum, it will make a big difference actually in the morbidity and mortality of such a diagnosis. We know placenta accreta, it has very big association with the morbidity and mortality and its consequences. Could we really avoid these complications? No, by all means we cannot. If we can make the patient and put her at the stand with us to witness what we are really facing. You know, sometimes when you do so much counseling, patient will lose trust on you. Believe me, it happened, and it happened even with me. But she said, why you are saying this يا دكتورة؟ أنت مش واثقة من نفسك. You don't trust yourself. أنا ما أبغى، أنا أبغى استشاري واثق من نفسه. قلت لها choose it. Please be my guest. Okay? But what is very important that she will know that you talk and you document each and everything. Most of the time things will pass okay, but when there is a time that where people they start to debate it and claim it, this is where you wish that. Don't you have this feeling when there is a claim, you'll just go back to your notes and you see your documentation? Most of us, we have this feeling. So just do it before it's too late for you. So make sure that when you admit patient, that her own consultant, and preferably, please, we know that we are on a stage of learning. Even us as a senior, you will never face the same thing twice. You will never have placenta accreta twice the same with with pen and rulers. It will not be the same. So it's very important, even if a junior consultant who is less than at least 5 years of experience admitted this patient, just show them that we are with you. I'm available. So that's why don't bring me from home at the middle of the night or early morning. Always planning OR is very important, and you know it is associated with very low rate of morbidity and mortality of the patient. Morbidity is very low with a planned elective cesarean section at these phases. So when you call your team, senior obstetrician, senior neonatologist, senior anesthesiologist, and you have to make sure that hematology is aware, or the blood bank knows that, because why? Every day you have to make sure that there is 6 units of blood is cross-matched. I know this will put them in toes, but that's it. It is what it is. We have just to follow it as such. So we will start with the senior obstetrician, and we mentioned it before, and it comes in the risk assessment and with the communication skill. Senior neonatologist, he will know and will try to push it as much as we can, up to 34. Otherwise, up to even 36 plus 6, we can say that one. But if we think that this patient start to have a bleeding and she start to play with us and it is still until now is affordable and we can, again, okay. Okay, it's talk mainly, it's okay. طلع? Okay. Still, we are in the essential multidisciplinary team approach. Essential. There is essential and there is supportive. I hear so many talks and I really respect it all, but let us go into practical point. So patient has to have these things and it is very important. So when you have multidisciplinary team meeting, there is an essential people that you should make sure that they know that you have a past patient with you inside the hospital. They have to be aware. Do you know why? And personally, even I'm just a consultant, I will let the one in charge, I mean the chief of the anesthesia, chief of ICU, the chief, why? Because it is his job to let his colleagues be aware of it. Why? In the good days, it will be just a bland one and everybody will tell everybody. But if you think it's emergency, do you think you should just tell one? So it's better you tell the one in charge, the chief of the ICU, the chief of the NICU, and you make sure that there is a blood available. And even, by the way, in the counseling, because some of the patients, they think, why you give me blood? My God. So make sure that the patient will be aware that we might initiate blood transfusion drill at any time in the OR. So she should know that we might end up with this thing. There is another thing I need to tell you about it, by the way, about the consent. Let me just elaborate little things about it. You know, the consent, it will have a general, like any surgery you will go for it, and it will have a specific. And do you know, when you have a placenta previa, it is a concern, it is of a concern. But I would say I will just include it as previa and accreta. It will be all the same thing that you will include it. So make sure, when you come to put the consent, put all the cons and pros of a previa, not just accreta and the consequences of it. So please, when you come to do the consent, make sure that the patient is really aware of it, the husband is aware of it. Because it's very easy for them to say, we haven't been around, it was not there. And make sure in one of these visits that, because they will not call the resident who did all these things, they will call the consultant. And they will tell them, the one who took the consent is not the one who went to the OR. And you could find somebody he can play it very funny, okay? But sometimes you will find it like that. So make sure that in the note that consent was taken, all the pros and cons. And you know, if you are too lazy to write anything, what you should write? Patient counseled fully. طيب play it right. يعني انت احيانا ممكن تعدد كل الكومبليكيشن اللي موجوده في العالم. But sometimes you might miss something. We had one scenario of a patient. She was young and she passed away. Unfortunately, she died. And she died because of a complication of irrelevant to anesthesia, because she was pregnant. And the husband was he was so meticulous about it that this patient was not aware of all these things. And nobody explained this to us. By the way, this is a very general thing. Nobody explained. It was a complication of invasive interventionist that he got enthusiastic with his job, and the patient complicated and died. So what happened when they call us? We found the consent. It was shredded into 2 papers. Yani it's an old file. So the consent, it was shredded into 2 papers. And he was mutawwa, and he was like this, and I was nearly tell him to swear that he doesn't know about it. We, subhanallah, found in the consent at the very angle that death la samah Allah. Look at what these people is looking. Death la samah Allah, it's written. I told him, you signed, this could happen to her. He said, is it me? I told him, I don't know, you tell me. So it's written. So make sure that when you come to do the consent, وبعدين very thing, another trick I will tell you about it. It's very good. You know what you should write in the consent? Fetal maternal morbidity and mortality. This one very wide, صح? It include everything. حتى لو أنت نسيت شيء, it's written there. Patient was counseled fully about fetal maternal morbidity and mortality. We can write whatever you want to write. شوفي في أحيانا consent ينكتب فيها العربي. طيب؟ في consent لا اكتبيها لي بالإنجليزي. أنا كانتريجيتر. طيب؟ أنا بقراها لت أوكي؟ هو وقع على إيش؟ أيوة بالعربي. طبعا الكونسنت تنكتب بالعربي بالإنجليزي. مضاعفات الحمل على الأم والجنين. If you have time.
You can write for example. يعني
على سبيل المثال.
لو حصل.
أنا شخصياً اكتبي لي fetal maternal morbidity mortality. طيب؟ اكتبي لي this is good enough for me واكتبي كلمة counsel. تذكروا دائما هذه الكلمة counsel. أوكي؟ طيب. Okay, this one you finish with it. Remember, this is the essential one. This is the essential one. I know people will debate about what is good, which one is more effective, and let me tell you. Now I can tell you really, placenta accreta spectrum is a very personalized. In general, there is so many evidence base for you. So many evidence base. But you cannot treat patient, you know, it's not just a copy. Sometimes, actually most of the time, patient will be personalized. You will feel this patient needs to be treated differently than this one. So this is essential. Okay, lastly, see, I told you my lecture is little and so on. I have so many talks, but little things to remember. This is the multidisciplinary approach, which we always call it supportive. In which way that I need to call the urology, general surgery, radiology, and oncology if you need. Because in some, it's very luxurious. I will tell you something, by the way. Why in the Western country, people, they do so many meta-analysis and they do all these guidelines and they do evidence-based. Do you think they do it because they want to help us? No, let me tell you, it's not. Always their aim is what is cost effective, what is not. It's always money, what makes difference with them. We are really grateful in this country. Money, it has no value with the patient health. But that's why I'm telling you that when you go to the Western country, when he tell you that, because now we will say, okay, we have interventionists. We can't do it here. We have oncology, he can come with you. But in the Western country, everything has a price. So when they tell you it's not cost effective and it is not evidence-based with us, guideline with us, but it is mainly cost effective with them. So what makes difference with them is not all these things. The conclusion is mainly, it's for a law, for any litigation, it helps you in that one. So we said urology. Would you call urology for each placenta previa or placenta accreta? Is there an evidence base regarding that? No. But honestly, this is when I tell you personalization. If this patient you think she is percreta, definitely you might need or consider the help of urology with you. You might need stenting. It's not a luxurious, well, let's say it's a luxurious thing. Sometimes it's very important. And let me tell you story time, funny story. That after you do the stenting, you can cut the ureter and make sure that it is ureter with the stent and give it to the urology. Okay? فهي cannot deny إنه عنده شو اسمه. It's not evidence-based. And I will not mention cost-effective. I told you, we are in a very blessed country, alhamdulillah rabbil alameen. Cost of no value for our patient. Alhamdulillah, our patient is beyond that. So we are really grateful. But for the sake of that, is it evidence-based? Is it? But I'm telling you, some of the cases I might need him at least to put a stenting for me to know my way. At least even you see, remember Dr. Lamia when she tell you that the uterine is really below the ureter is really below the uterine. So she has to take the ureter with the uterine. She has to do it. So it is what it is when it comes to time. And nobody إن شاء الله خلاص قربت؟ خلصت والله؟ زين طيب أوكي. خلاص باقي بس واحدة هذيك عاد مهمة يعني حقت شو اسمه. طيب كان أعطيتني 5 دقائق ذي warning. Okay. So any of these which is listed here, urology, general surgery, radiology, interventional radiology, oncology, there is no evidence base about it. I'm telling you that. Okay. This is just a general consideration, and this is the talk which I could tell you about it, and I will take it in a fast manner. Okay, the general consideration: when to admit patient according to the diagnosis. If the patient could really go beyond 34, we'll be grateful. Otherwise, admit her early if she starts to have a bleeding. Tuberculosis, the only evidence base in tuberculosis is what? Just to finish the DEXA. Otherwise, it has no rules in it. Steroids, it will just go with this one, and it's better if you could give it as early as whatever. I will not tell you at how many gestational age, because it's really debatable. And it's up to you. Once the patient starts to bleed, she's giving you warning sign. Use it, please. Don't say that I will not give it until I approach the 34. Give it earlier. You might take the patient overnight, على فكرة. Timing of delivery, as I told you, personalization still. Why? Because you might go, we will be very pleased if we could just pass the 34 weeks, by the way. Otherwise, if she is stable, she's not giving you any warning sign, you can get her in. At what time I can get her in? If she is not giving you any warning sign, you can keep her up to 34. Bearing in mind all these conditions, that you assess the distance of the patient, how far she is. It has to be less than 20 minutes, and even 20 minutes it can be that serious. You have to make sure that that patient has accessibility, or somebody is around 24/7 to bring her home, to bring her to the hospital if she is. Listen, don't bargain with these things. Because the mother is so emotional that she wants to stay with her kids, but you have to get equal emotional that she has to be in the hospital with these conditions. If you know that this patient could bleed till death, you know, I will tell you just last story. We have one patient, she was in the 4th floor. By the time we get her to the OR, half of her blood was left. She bled like 3 liters, just getting the patient from the 4th floor to the OR. So bear in mind that distance is very important. Availability, accessibility of the patient to the OR is very important. VTA prophylaxis is very, I would say, very debatable, by the way. If you think patient is not showing you warning sign, you could consider it, especially for high patient who is more liable for VTA prophylaxis. Otherwise, if you think this patient is really not giving you any comforting sign, don't jeopardize it. Still, I will tell you it is personalized and according to the patient situation. Anemia is prohibited in these patients. Prohibited, prohibited, prohibited. Sorry for making it long. I thought it will be just a few minutes. Okay, thank you.
Thank you so much, Dr. Mariam. Any questions for Dr. Mariam?
Very experienced. Comes from experience of a master.
Okay.
Our next lecture is a collaboration between two great consultants, Dr. Nawal Abdullah Al-Harbi, highly esteemed senior obstetrician gynecology consultant in King Saud Medical City. She's the head of the bleeding unit for placenta previa and placenta accreta spectrum management in the same hospital. Along with her, Dr. Mferrah Ibrahim Isa, consultant obstetrician gynecology in King Saud Medical City. He is also the maternity emergency department chairman in the same hospital and the quality officer in the same hospital. He's certified professional in patient safety and credentials. He had 16 publications, among them the blood consumption in placental abnormalities and many reviews upon PPH and abdominal pregnancy. They both have collaborated in this lecture, which is Best Surgical Approach for Placenta Accreta Spectrum. Please welcome.
Good afternoon, everybody. Thanks for your introduction. Thanks for introduction. It's clear? Actually, it's a pleasure to be with you today. Thanks for organizing committee, scientific committee, and thanks for really warm welcoming. It's really a pleasure to be with other experience, and pleasure also to see some friends, all the friends. So actually for this lecture, when we received the topic, me and Dr. Nawal, you know, she's the head of bleeding unit. And really, it is my opportunity to have a talk with Dr. Nawal. So regarding the best surgical approach for BAS. So we were asking ourselves, what does it mean, best surgical? It's from view of obstetrician, it's from view of patients, both, okay, it's morbidity, mortality, okay, it's from blood, okay, so we try to go through the literature, okay, and at the same time we told, let us to share our experience. As a tertiary center in Riyadh, King Saud Medical City, is, you know, it's well known to everyone, okay, and for the last couple of years, we started to be recognized as a center for referral for such patients. So it's an opportunity, and I think it is shared lessons for all of us to share our experience and compare to the best available evidence worldwide. So this is our agenda, okay? It's including the introduction, but I think I will pass it because it's already covered by my colleagues. KSMC experience from placenta previa and BAS management, conservative surgical management modalities, and cesarean hysterectomy modalities. Then we will talk about conclusion. So, what is the best? To be honest with you, you know, I will leave it for you guys, okay, to follow our lecture, and by the end we can, you know, agree what could be the best. So I would not go again through the incident and etc. and definition. So we know that the number of BAS is increasing, as you mentioned. So multidisciplinary care team already covered by Dr. Mariam, and I think she mentioned all the team needed. Okay, and when we you know, decide that we will establish organized services for placenta previa and BAS, we had meeting with all those stakeholders, and it was in 2019. So actually, one of the things that is very important, you know, in for us as an obstetrician and a surgeon, mainly in OR, I think, and we had an anesthesiologist with us. She presented herself this morning. That's monitoring. To be honest with you, monitoring and anesthesiologist on the other side of the patient, he's your eyes. For us as a surgeon, we are keeping attention and concentration in the field. We don't know what's going around. Sometimes we don't know how much the patient lost. We don't know how to when to activate, for example, MTB. Okay, what is the best fluid replacement? And we know okay, and I think everyone shared me this, okay, that I prefer this anesthesiologist to be with me in such difficult cases. And sometimes we are going and calling them, please, I have a difficult case, if you be with me, okay, or you and your team, that really help us, because he's really, her or his role is very crucial for such patients. So inside OR, there is a rule of thromboembolism prophylaxis. From up to date, they told that it should be placed as the surgery itself, okay, hemorrhage, blood transfusion, can increase the risk of postpartum venous thrombolism. And we had cases, we will share with you our experience. Blood products. So in King's Old Medical City, we had established MTB, massive blood transfusion protocol, and we have a hotline. So since we started from the junior to the senior one, we know what does it mean MTB. So blood and blood product availability, it's a must. And thanks God, in King Saud Medical City, we had the regional Riyadh blood bank, and all the support all the time is available in this bank. So what we did, okay, as KSMC receiving emergency life-threatening cases, booked and unbooked, and to be honest with you, 70% of our patients are unbooked. And also we receive unknown patient, either immigrant or those who are living without IDs. Moreover, maternity hospital is the only tertiary hospital in Riyadh, cluster 1, that receiving case of placenta previa and past. And will be recognized for this, even not for Riyadh, for other area outside Riyadh. So we are receiving either through a HALA hotline or from our R1 hotline, or some walk-in patients. Some patients also are receiving from 10-6 system. So because the rate, as you mentioned, is increased, so that time in 2019, we decided that we should establish bleeding unit. I mean, organized bleeding unit. The aim of the unit is to implement standardized management of placenta previa and pus according to the latest available best evidence medicine. So, the project of bleeding unit had 4 phases. Establishment phase. So, during this phase, we initiate our protocol policy. We had an expert personnel in our hospital, from senior obstetricians. We have oncologists also with us, plus other specialties, urologist, anesthesiologist, etc. So we adapt the role of second on-call consultant. So there is primary or first consultant on-call, and there is a second. As I mentioned, senior or oncologist sometimes for cases of placenta previa and pus, and mainly pus. So that was the first phase. Second phase was implementation phase, which was training for all senior registrar, in addition also to Saudi board resident. So to be honest with you, that some on-call, we had like 2, sometimes 3 cases during one on-call, since we start to establish our unit. The third phase was optimization phase. So it's be recognized, as I mentioned, for all facility in Riyadh and also facility in other area of kingdom. And inshallah, we had future plan to be recognized as center of excellence for placenta previa and pus, and we are working on such plan. So this is our policy when we started our unit. So that's our figures, okay, from 2019. So this is number of cases of placenta previa and pus. Okay, so we had total of 780 patients. If you notice that our patient number is increasing, we start from 149, and last year we had 192 patients. So our hysterectomy rate as a total for previa and pus was 22%. Actually, RCOG, they mentioned that 27% for cases of PAS. The good thing, alhamdulillah, we don't have any direct maternal death due to PBH since we start this unit, 2019 up till now. Only one patient we had death, but it was due to FTE second day post-operative. So really we are proud of such an experience. So what could be the conservative surgical management of PAS? So if you go to the literature, there is a lot of modalities, okay? And to be honest with you, there is a lot of debates regarding these modalities. And in OR, actually you want to save the life of your patient, okay? You cannot remember all the theoretical things that would mention the guidelines or in the papers, etc. Like infading 50%, infading less than 50%. In OR, we're not thinking like this. Patient is bleeding, I have to take an action. And this is the emergencies of such cases. And it's a nightmare for us, calling after midnight for patient coming from ER, your senior start calling you that, okay, I'm expecting this patient is PAS. So I'm shifting her now to OR. Just calling the MTB, I'm taking her now to OR. So, what do you think? Of course, everything or the theoretical things is not in my mind. Either the placenta will come by itself or I will go for hysterectomy. That was our thinking, really, to be honest with you. But there is a rule, especially for some elective cases, team, okay, prepared cases. Yes, it could be. So who's the candidate for conservative? Most of our patients want to preserve their fertility. And the first question in recovery, that doctors, did you remove my womb or no? This is the first question. Then she will ask about her baby. But the first question is, did you keep? Once you tell, okay, but she is PAS, okay, and Berkrita, we removed because we saved you. She will start to cry. Then she, even the husband. Yes, okay. In other cases, when hysterectomy is brought to have an acceptable high risk hemorrhage or injury to the organ, sometime, okay, either due to lack of facility or maybe due to lack of experience, so you need to leave the placenta inside, okay, and you will not proceed, or to have a delayed hysterectomy, okay. When the placenta section is thought to be possible, sometime for focal accreta, yes, there is a role of conservative surgical. Actually, in the literature on Vigo, they describe, some different ways or method of conservative, like extirpative technique, which is manual removal of placenta, leaving the placenta in situ, uterine devascularization, and triple P procedures. So just quick for those, okay, before going, positioning. All of us, we know how to position patients during cesarean section. For those PAS or placenta previa, placing the patient in litigious position or with leg flat on the table, but separated, provide access to the vagina. And really, I think some of you, they tried it, because it gives you an access to the vagina when you want to insert ballooning, or even for observing of bleeding, instead of taking the drop out and going down to check. So that could help. For the skin incision, okay, a low transfer skin incision allowing access to lower half of the uterus and can be performed. But to be honest with you, if the placenta is anterior and extending toward the level of the umbilicus, midline skin incision may be needed. And for us in KSMC, when we are expecting PAS, we are going immediately for longitudinal incision. Extirpative techniques. This procedure consists of removing placenta. Sometimes you will go for patient unbooked patient or patient just bleeding. So your assistant or you you will start to remove some part of the placenta because either you don't know or you want to help the placenta to separate, or you thought that it's still just it's focal adherent, so it can be removed. So It can be, but to be honest with you, most experts in the management of PAS consider that attempt at removal of placenta should be avoided because it could lead to bleeding and cesarean hysterectomy. But what about leaving the placenta inside to approach? I think some of you, they tried it before. So this approach consisting of leaving the placenta inside to and waiting for its complete spontaneous resorption. So sometimes, as I mentioned for you, that either due to lack of facility or the patient insisting to preserve her fertility and uterus, so you will leave the placenta inside. But this procedure need to be supported by other procedure, to be honest with you. You know, it's not like just leaving and that's it. So, you know, there is a limited data, actually, to be honest with you, for the conservative treatment of placenta percreta. Embolization, vessel ligation, temporal antenailiac ballooning, occlusion, as they mentioned in the morning, methotrexate, hysteroscopic resection, and maybe you need more than one session for hysteroscopic resection, used in conservative approach, where the placenta left in situ to decrease the morbidity to accelerate the placental resorption. What about methotrexate? If I lift the placenta in situ. So they mentioned that there is no evidence of methotrexate for patient with left placenta in situ because of the toxicity that can affect long follow-up of the patient. And we had one patient in KSMC. We left the placenta in situ, and we gave methotrexate, but to be presented by Dr. Nawal after a while. What about uterine devascularization? Preventive devascularization can be achieved by surgical or interventional radiology. Stepwise uterine surgical devascularization like bilateral uterine or hypogastric artery, iliac artery embolization, or balloon occlusion. But this facility is not available everywhere. And to be honest, the evidence for this uterine sparing procedure seem to be less effective in case of PAS. And as we moved to our new tower in King Saud Medical City, so we don't have such radiological intervention, or we didn't try it yet. Triple P procedure, it is 3 steps. First of all, preoperative placental ultrasound localization. Second one is pelvic devascularization, okay, like ballooning or divisions of the internal iliac. Then myometrial excision of the affected area. We are in KSMC doing such things, okay, mainly for focal accretion, that we are removing, then resuturing. And the success rate was good for this, associated with tamponade. So what we are doing in our practice, that if this focal accreta, we could remove it, mainly for the posterior accreta, okay? We could remove the part and resuture the defect part, and we are applying Bakri balloon. So the placenta removal followed by insertion of Bakri balloon was successful in preventing hysterectomy in 84. This is a trial by Pala. But still, efficacy remain uncertain. But this is our practice in King Saud Medical City. Usually we are combining with internal iliac ligation. We are doing surgical internal iliac ligation. After we are closing the uterus, we will go for internal iliac ligation plus ballooning. Now there is a new technique published in American Journal of Obstetrics and Gynecology, okay, by Jefosky, I think he's Russian, that double ballooning, and according to their trial, that it is really very effective compared to the classical or traditional surgical technique. So it consists of almost 5 steps. That first of all, they will apply it first in the vagina, and they will inflate it. Then they will go do their cesarean and taking the baby out and placenta. Then they will insert the Zavoski ballooning. Then they will close. To be honest with you, that they mentioned that it's effective for pass 1 up till 3. But for 3C, they will go direct for hysterectomy. Tomorrow, inshallah, we'll share with you during the workshop the video of these operations. Okay. The thing that they are doing is that to identify where is the upper border of the placenta. So you will go like 2 fingers, which is 4 to 5 cm above the placental edge. So you'll try to avoid going inside through the placenta. Otherwise, you will end by bleeding. So once they will identify where is the accreta, so they will take the affected part, then they will resuturing plus double ballooning. In KSMC, we had a trial before 2009, and they published by Dr. Nawal Harbi and Dr. Nasser Abbad. And really, I'm happy today to see Dr. Nasser. So they had what we call it uterovaginal backing. Okay, and actually it's 2 gauze. It's gauze of 2 meters long and 2 centimeters in width, which was soaked with normal saline into the lower uterine segment through the cesarean section incision, and its lower end was pulled down through the cervix into the vagina. The cesarean incision was closed in 2 layers with interrupted stitches, but stitches should be taken carefully to avoid going inside through the towel. So another same vaginal backing was inserted to the vagina fornices to counteract the pressure effect on the uterine bag and compress the pelvic vessels. So 24 hours they are leaving this backing, then they are removing it. Actually, the result was like we had 83 patients with postpartum hemorrhage due to placenta previa or accreta. 48 of them underwent uterovaginal backing alone as a conservative measures, and it was successful management. 3 of them, they need second surgical intervention, but there is no maternal death among all of them. So it could be used in case if we don't have, for example, Bakri balloon or another way of tamponade or low resources country. So it was really very effective. And nowadays we carry another study comparing this study outcome to what we are doing now with Bakri balloon, and inshallah we'll publish it soon. So I think this is end of my presentation. The second part will be for Dr. Nawal. Yes, Dr. Nawal. Which one? No, remove. Yes.
I put this here. Bismillah ar-Rahman ar-Rahim. Next. Bismillah. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah wa salatu wa salam ala Rasulillah. We came from Riyadh to share our, voice. مو مشغال يمكن. Which was one? I see. لا خليه كذا ما أحبه بيدي. أعطيني الكوب والغطاء حقه البلاستيك هذاك عشان بشرح عليه. بسم الله. السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. We came from Riyadh to share our experience with Dammam. So I think Dr. Mfarrah, mashallah, he presented our unit. We should, all of you know that PPH is the main leading cause of maternal death globally and also in our country. The WHO made a new roadmap between the period 2023 to 2030. And the aim of this roadmap is to reduce maternal mortality and morbidity from PPH. And they reported that we must save mothers and we must stop PPH. Now, hysterectomy. Shall we do total or subtotal? ACOG reported in 2018 that total hysterectomy should be done for all cases of PAS, while FIGO recommendation is subtotal hysterectomy for placenta accreta and total for increta and percreta. If we talk about experience, we may remember what Albert Einstein said, that learning is an experience. Everything else is just information. What is our experience at KSMC? We thought that, and this is our experience, if women or a patient needs hysterectomy, subtotal hysterectomy is enough for all PAS cases, accreta, increta, or percreta. And 65% of our cases were managed by subtotal hysterectomy. And none of them needed reopening for post-operative bleeding after subtotal hysterectomy. Here we have to remember when we do the subtotal hysterectomy, we have to be very careful. Where is our cup, Doctora? Yeah. We noticed from the cases we did, many cases, that placenta is not going into the cervix. Placenta is just like a dish. This is the cervix and this is the placenta. And it's just sitting like this, like a dish. And when we do subtotal hysterectomy, we complete our uterine ligation, and then we go to the pedicle, the lower segment. The assistant will push the placenta upward like this. And the two surgeons, they put the clamp below the placenta, between the cervix and the placenta. And then they just excise and chop the uterus out. Then we close our pedicle at the lower segment. It's stretchable. If you put Alice, it's stretchable. And we put clamp, then we excise the uterus, and we transfix our pedicles and secure hemostasis. At the same time, and then we'll inspect our cervix. Make sure there is just some mucus coming through the cervix, no further bleeding from the os. Usually you will find just some mucus within the cervix. And then at the same time, our second assistant will inspect the vagina. Will clean the vagina from all the bleeding and clots and make sure no further bleeding. If no bleeding from up or down, that's it. We just put drain and we close. This is our technique. And now, is this PAS or scar dehiscence? How to know? If you open the patient and you found this defect, this one, if you notice that there is defect in the myometrium. However, there is no increased vasculature on the defective area itself. Yeah. And no 4 months in the gynae clinic. At night, she came with emergency uterine bleeding and she had hysterectomy. During hysterectomy, it was noticed that the placenta is within the uterus. No invasion of uteroblast out. Only thick adhesions between the lower uterine segment and the placenta. And when they dissect the area in between, they separate the bladder from the lower uterus, the lower uterine segment. It was very adherent, but there is no significant bleeding, decreased vasculature. The second one was para 3 plus 0. She had 3 previous cesarean section, and she presented to us with hematuria at 36 weeks. The same, all a urological assessment was done. Urine analysis showed high level of RBC, but cystoscopy was normal. So this patient went for elective CS at 36 weeks, on maybe several days after admission, after assessment. And surprisingly, the ultrasound showed accreta. But when we opened, the placenta came spontaneously, and the lower segment was not thin, and we just put Beckery balloon and came out. So not all hematuria is percreta. Intraoperative experience at KSMC, we noticed that from the many cases we did, that placenta does not invade the bladder, and only bladder is adherent to the lower uterine segment. And after releasing the adhesions, the serosal adhesions between the bladder and the uterus, we noticed that there is increased vasculature at the posterior bladder wall with large tortuous vessel. And this is, I think, what Dr. Iman this morning, she presented in her ultrasound, that she said bridging vessel. So our personal opinion that trophoblast are normal cells. It is not choriocarcinoma to invade other organ. Maybe you need to do more study, and also we will do, inshallah, to prove this or disapprove. So we review the literature, and what we found that although it is reported in the literature that placenta percreta can invade the bladder, but there is no definitive, clear surgical or histopathological data about that. We review the literature, so many papers about invasion of the bladders, so many papers and case reported. But we noticed that all of them were old, 1989, 1981, and 82. Reviewing more literature for the new one. Here, Eric and Graham, they reported the pathophysiology of PAS, and their report was that the current data continue to support the concept of biologically defective decidua rather than primarily abnormally invasive trophoblast. Again, another paper on 2021, they report that placenta adherent to the serosa of urinary bladder, but no involvement of bladder mucosa or muscular wall. Eric and Ahmed Hussein, they studied 161 sample, 160 sample from accreta area of 47 cases of patient, and they found that there is thick fibrinoid deposition at the utero-placental interface by microscopic examination. And their findings, they made findings, and their conclusion again to support the concept of that accreta villus tissue is not truly invasive. Another study in 2022 by Dever and Eric, they said there is no evidence that accreta placentation, that extravillus trophoblast is abnormally invasive, or the villus tissue can cross the uterine wall into the pelvis. So it is not a matter of invasion anymore. It's a matter of a placental localization, vascularity, and adhesions. how to reduce PAS, if we want to reduce PAS, we have to reduce the cesarean section rate. And how to do that? By reverting to our obstetric arts. And how? By training our junior doctor, the management of normal labor, instrumental delivery, assisted breech delivery, and twin vaginal delivery. And by teaching them and involving them with us in the intraoperatively in these cases. So no more placenta or PAS is nightmare. It is, if you know things, you will not be scared. You have to be brave and think of saving mother life, not of medico-legal issue. If you put medico-legal issue in your mind, you will not save mother life, and you will not learn, and you will not achieve your goal. Our aim is saving mother life. To save mother, don't think of anything. Think of Allah and the reward from God. So, in conclusion, the key to success of PAS management is to have coordinate, multidisciplinary teams between providers with the high level of skills that comes with experience in treating the condition. It's a teamwork. Then, accurate diagnosis is the first step towards this goal. Pelvic imaging is essential, and intraoperative diagnosis is the mainstay, and it's a challenging intraoperatively in emergency cases. And thanks. Inshallah, in the workshop, we will show you some techniques you may get benefit from.
Thank you so much,
Yeah.
Dr. Nawal.
Any questions?
Dr. Nawal and Dr. Farah? Yes, please.
Any question, please?
Thank you very much for very stimulating and exciting lecture. For me, this lecture is particularly important because I think people have not enough that I will say. There are two particular papers I think you should push out, or three, as it were, to help the world. Because what you are doing is not easy. And I think one of the problems we have is that we leave so many things to the Western world, and it does influence management. So we should lend your voice, because it's also going to help the world in the direction today. One is this because I like the confidence with which you said that subtotal hysterectomy, there's no problem with it in this management. And I want to get back on that to help us go towards ego. Because this invasive surgery is usually a problem. And we know the advantages of subtotal hysterectomy in this case. So if we can help people to go towards that, and they can keep proving that, it will help the world. It's not, about help obstetrics and help the women.
Yes.
So I think that study should be pushed out as soon as
Yeah, we have a study. It will be published soon,
Please.
inshallah, regarding this.
So
And this shows the advantage of subtotal, that shorter OR life, less blood loss, and less transfusion, less need for mechanical ventilation, and it will shorten the length of stay of the patient in the hospital. This all advantage for the subtotal.
I think another arising from here is this question of bladder inversion. In fact, that is the most scary, one of the most scariest things you see or can imagine about this, which is why urologists must always be there. They must always be there. But you've made two important statements from those studies about bladder inversion.
Yeah.
The question is now, why hematuria? That's one other thing we'll have to find out, or this.
Yeah.
I
will take
try and guess that. Then secondly, it's important to show, that's not ever in medicine. It's not like placenta previa does not infect the bladder. But we reduce the fear, and that will help us also manage this problem. So I would also want people to do something about that.
Yes.
If you can use those two reported cases, the literature review, to push home that. So that more people will look at that and help us, once we reduce that fear, like the woman that had a hysterectomy, if we're almost sure from this kind of paper that it's not very likely. She could have been encouraged to at least get a child with viability. And because you are thinking of material emotion of the bladder, there's nobody that would say, if you don't have to say, let this baby go.
Yeah.
I think those, from this, what you've just done here, I just think is wonderful. You must move them out so that it can let the debate go on. That's what is science.
Yeah.
The day they can't tell it, fine. Otherwise, the evidence stands. So with the literature review and these two case reports about bladder emotion, I think they are wonderful.
Yeah,
so let's try and push out those papers. Let them help the world. Because this is a very rare situation, and you hardly find such centers as yours, where you have specialist center on this case. That's why it's important that you do something fast, because, well, from Saudi Arabia, nobody can even, no other center, I don't know any other center that can do it. And moreover, you have the authority to also give us what data that we have here, so that we can work on it, and not data from above. So I think arising from this, that's what I would suggest, so that will also make this workshop to be more meaningful to all of us. Thank you very much.
Yeah. Just for you, Doctor, to add that when we open a catheter, usually we fill the bladder partially, and we will separate the bladder from downwards, then the whole bladder will come out. And we separate. When we separate the bladder, we notice that increased vasculature, very large vessel on the posterior wall of the bladder. And those most likely is the one gives to hematuria. And cystoscopy is normal. Even in the literature, no evidence that trophoblastic tissue seen inside cystoscopy, just hematuria and hyperemia. Yes. Yes. Yes.
As regarding the subtotal hysterectomy,
yeah.
What you have said about the advantages of subtotal hysterectomy is for general hysterectomy, or any other reason,
No, I'm talking about PAS.
Yes.
Yeah, PAS cases.
In this condition, you see the problem is that, of course, subtotal is much better.
Mm-hmm.
But in accreta or in placenta previa, when it is centralis, and then you said your technique is that to ask the assistant to pull the placenta up. I think this is very risky.
No, doctor, it is not to pull the placenta. I will show you. Just here, this is the placenta. When we take the uterine artery, finish our pedicle, secure the hemostasis, you will go down to the lower uterine segment, isn't it? Huh? And here you will find like this. My registrar, I will just squeeze like this for them, to push the bladder, push the placenta up. There is little here, some uterine tissue. They will put the clamp here, and they know they are with me. So just not pulling, squeezing the lower uterine segment like this, doing like this to push the placenta up, so they can put their clamp below the placenta, and I squeeze. Yeah. Yeah, I'll push for them, they will put clamp like this. Yeah, just squeeze it. Yeah, upward, like this. No, not pulling. Squeezing like this, and they will put the clamp under my hand here. So this area, then the whole placenta is going up. It is sitting just like a dish, like this. This is the cervix, that's why I brought those. This is the cervix, and this is the placenta. We just squeeze from here up so they can put their clamp here. And then after that, if you noticed, just the os, you will see the os, mucus coming. No further bleeding inside. That's what I mean. And we make sure inspect vaginally also. That's why we are sharing our knowledge. Not everything in box. Yes? Yeah.
In these cases, how much the blood loss? You found it has decreased the blood loss from total hysterectomy?
Sure, yes, much blood loss, much less than total hysterectomy. Because if you go for total, you will go down, you will put the vaginal angle, and this is a pregnant patient, lady, and the vaginal angle plexus there, so many bleeding. If you do subtotal, it's much easier and much blood loss. You will avoid the vaginal plexus at the apex of the vagina. Yes, hello.
Conservative surgical, اللي هي dissection.
Yeah.
أسمع لأني هل فيها هو بالنسبة لكم فرق you mention it.
Yeah.
literature less than 50%, more than 50%. Okay, but actually inside work we have said about 50%. Okay, but for focal, focal, that which you can resect it. Okay, you can resect. Okay, and this is the same technique by Chifrinsky. Okay, then is suture.
How you do the resection?
Just 1 minute. Can you send that resected section to histology? So we can start having an idea of invasion of the placenta into the cervix. That is another thing we also can establish to help what you are saying, to help that method. Because if we can find average invasion of the cervical tissue by placenta, we might find out also make a point that it doesn't go so down. Remember that the cervix is 5 cells. So it may not go down as much as it can go in the uterine body. So if you can send the cutout to histology, let histology determine the degree of invasion of placenta on the histology tissue that is left.
You are right, you are right.
Yes.
Study will be done on that, yeah.
On this, it will also support, partial subsidized hysterectomy.
My question is سألت كثير في أيام our meeting regarding regarding resection. What's the future outcome regarding preservation?
This regarding the resection, you see there are many papers done by Dr. Al-Mubarak. You know, he was the president of the Royal College, and he used to do this routinely. Okay, and then he said, and he's following the patient. He said just he does that resection.
Yeah. What kind of resection, doctor?
It depends on the situation. He takes the wall of the uterus, yes. He takes any wall of the uterus which is adherent to the placenta. When there is a placenta accreta, you see, then he removes the uterus together with the placenta. And then, then he prepare the defect, then he try to suture that defect. And then he said the outcome is okay. He said this is, and then he published this. He saw this
cases get pregnant after
Yes.
Just like myectomy.
Yes. Yes, you can go to the research shop and write Al-Kumaran, and then you find plenty of papers about this and a good number of cases.
The one for these cases, the one for not suitable for any kind of patients who want to preserve their fertility and other kind of management that being failed, and we can go on this one.
Yes.
Thank you.
Thank you very much for nice lecture, Hamid. It's very open together. I just want to know whether you said that resection of focal is predetermined or intraoperative findings. And then, هل هو anteriorly or posteriorly, or how much is area you should decide to resect so as you can just decide whether she's for resection and repair or to proceed for extraction?
Usually anterior, the resection anterior at the scar site.
Like if it is posterior, if you feel that, if you find...
Usually,
it's intraoperative findings.
Usually what you know, that even you know that the adhesion at the scar site, most of the time, the adhesion at the anterior. Posterior it will separate.
Sometimes using makeup from posterior. The area of resection, definitely you can imagine the larger the area you remove, the difficulty to repair. But you have any, I mean that it is just a subjective, it is just personal, you just see how much tissue you should remove.
Pregnant uterus is large. When you pull them together, it will come together. Then it will retract later on.
So it is a personal evaluation and that.
I will give you some hints about it. As an evidence-based, by the way, when there is a focal, just adhesion, it's preferable to leave it, provided that it's not bleeding. If you know that there is a focal thing. What's the trick is that how you go around it to avoid it. خلاص انت بتشيل بس انت عندك focal adhesion. انت فوق ايوه انت واحده راسك بس في الجدار and you want to يعني resection is really sometimes they will bleed. So what do you need to do? ارفع المونوبولر إلى 50 ولا 60. طيب ايوه شفت المونوبولر حقك هذا؟ ارفعه إلى 60 ولا إلى 50 كذا. طيب and take it in very small bite. لا تاخذها كلها مرة واحدة. فهمت علي؟ Secure it. أنا هذا قصدي. Try to secure it in bits and pieces. لو هي معاك موجودة ولا bleeding, leave it close.
معناها this is a different approach.
This is so زي أنا قاعد أقول لك. أصلا most of the literature تقول لك لو عندك small piece و not bleeding, leave it close. طيب لكن لو أنت عندك مثلا يعني you feel it's a big size dose ولا حاجة فأنت الأبروش حقك لازم يكون very careful. إيش اللي عندنا طبعا أنا ما أحب الدعايات لكن we should really mention it. We have a very beautiful machine اللي sure. طيب if you could have an impact معك no need for its approach. أنا أتكلم عن مكان ما عندهم الفاسيلتي حقت اللي sure it can seal the tissue beautifully. You can seal it طيب and it will not bleed. اللي sure مرة جميل. يعني وبعدين أي نوع من اللي sure مو أي شيء. يا تاخذ مثل الأطلس السمول أو بريفيربل طبعا أنت لو الأطلس مو موجود خذ الإمباكت. الإمباكت مرة كويس وعنده بيج بايز يعني حتى السيرتون يوصل the time I do it with the impact. طيب very fast وكذا. فأنت لو عندك small piece مش bleeding you really secure it. تتأكد إنه مش bleeding.
طيب أنا بس قصدي ليش أنت from the start when you go inside definitely you will decide whether to go to the center or to go closer.
I will give you a scenario.
I never leave the placenta.
I will give you a scenario. For the last 3 weeks, Dr. Abbas.
Story time?
No, it's not a story actually. It's not a story. It's a case report. I mean, it's in our hospital. Your question when you tell how to manage or what's the size of the what senior
yes, how much do you need? Yeah. Okay.
He just by elliptical incision at the site, and he just resected all. Patient was I think paracord or something, just preserved her uterus. It was horrible bleeding, and we couldn't feed it. The iliac failed, and this is what the last resort just to preserve their fertility and to walk. I never read the doctor regarding what is the size, how is the incision. Doctor Mufarrah, you read a lot.
This is a variable.
Yes, but there is nothing to say. I mean, this size incision, this depth, this wear, this. For me, I never read it so far. Maybe we will do.
The only one, honestly, the only one who can tell is the surgeon. It's really very individualized. You cannot decide about it. How much to leave, what to leave, when to leave, and your approach. You are the surgeon there, and mostly it's intraoperative. Okay, sometimes you will give a radiology result as it's not an accurate.
I just asked them because they have the experience. But I saw that from their experience they may advise us. But the thing is that from the start you will just decide whether this is for conservative surgery or for hysterectomy. Right? And this one, well, actually, if some patient you may go for hysterectomy from the start. And some patient you may just try.
Be safe, honestly, and just put it in the consent that it's there. So for any consequences that you are not missing it intraoperative.
Doctor, just to,
I love your slide, the last one.
Yeah,
I love it, this report. How just to teach the junior the practice. We should practice the optimal way, how to prepare a cesarean delivery. We should practice how to deliver the breech vagina. We should practice more how to deliver twin pregnancy and to return back to back. And all of this should be returned back to the old ages at our age.
Yeah. Now, just a message to us that obstetric is a social medicine. We know more than the blue eyes. We should not wait for their study. We should report our cases. We have a lot of cases, more. Okay? And then the new generation, we should involve them in these cases early. So they will build up their experience in dealing with these cases, particularly Bukram people. Yeah.
Coming to the end of our day with the esteemed Dr. Murtada Muhammad Al-Nimr, consultant urology at the MAM Medical Complex. He masters urology, urological and neurological procedure skills. Dr. Murtada had published 3 articles in his field, and he will be presenting to us the urologist rule in placenta accreta spectrum. تفضل دكتور. هذا عشان التسجيل إذا ما عليك أمر.
Assalamu alaikum, مساكم الله بالخير. It's my pleasure to be here with our colleagues, and thank you for the organizing and scientific committee. It's my pleasure to be here, and thank you for the organizing and scientific committee. And I think this is just the routine scenario. We are called at the end of the surgery, so they kept us at the end of the day. A quick introduction about the relationship, the anatomical relationship between the uterus and the urological organs. All of us knows that there is close proximity for the uterine, vagina, bladder, ureter, and the uterine arteries. This is make logical data that the unintentional genitourinary injury with the placental adhesive disorder reaching up to 29%, comparing with 4% in the regular gynecological surgery. So there is significant number of urological injury during these disorders. As previously mentioned, hematuria can be found in 25% of cases. Other consequences is bladder injury and ureter injury. Evaluation usually done by our colleague in gynecology. This include ultrasound, MRI, and cystoscopy if needed. This is the most common injury, is the bladder injury. And most of the time, our colleagues, they take this part, they repair the bladder, even before we reach the theater. So just the basic principles, should be 2-layer closure using absorbable suture. So we avoid, when we use non-absorbable suture, there will be high chance for forming bladder stones. So non-absorbable suture is preferred. And we should keep the Foley's catheter 2 weeks after the closure to give the bladder chance to heal probably. And after 2 weeks, we can remove the Foley's catheter. There is no need for routine cystogram. If we are happy about our closure, we can just remove the Foley's catheter. Sometimes when the bladder is widely injured, opened, at that time we can observe both ureteral orifices for urine jet. So we will be comfortable that the urine is draining and most probably there is no ureter injury. The other consequences, which is a little bit difficult to assess and needs some skills to treat, is the ureter injury. As we know, the ureter goes anterior to the iliac arteries, and it goes just posterior to the uterine artery, which this makes it very liable to injury. Overall, ureter injury found in 0.3% of gynecological surgeries. Of the all iatrogenic ureteric injuries, hysterectomy is counted for more than 50% of ureteric injury due to the close anatomical relationship. And with the placental adhesive disorder, there may be disturbed anatomy. So this makes it even more liable for injury. One way to theoretically to reduce the ureter injury is preoperative stenting. I will talk about this in the next slide. The point about ureteric injury that it's most of the time goes unrecognized. For unrecognized ureteric injury, there is some consequences: urinoma, abscess, ureter stricture, urinary fistula, and even loss of the ipsilateral renal unit. There is multiple type of ureteric stent. This can be inserted immediately before the procedure. It will take a short time. However, sometimes it's difficult to identify the ureteric orifice due to the pathology and the physiology of the pregnancy. The most common type is in the left side, the double J stent. And the other type is the ureteric catheter. Most of the time we prefer the ureteric catheter because it is longer, can go outside the urethra and can be attached to the Foley's catheter. So at the end of the procedure, if we are happy about the ureter, we can just remove it with the Foley's catheter. The literature showed that ureter catheterization will not reduce the ureter injury. It will just increase the identification of the ureter. So the risk of the ureter injury is there. One new novel technology is the lighted double J stent. The double J stent with a fluorescent part that can be seen even beyond the ureter. This is a very nice new technique. And the new literature, small series, but it showed that it is significant reduce the ureteric injury, especially for the laparoscopic and the robotic surgeries, whereas the tactile sensation is not there. So the surgeon can easily see the ureter. So when we have ureteric injury, sometimes it goes missed. We did not notice intraoperatively. Post-operatively, patient might have fever, abdominal pain, hematuria, or urinoma that will cause pelvic mass and leukocytosis. So how to identify the ureteric injury? Usually, we can start with ultrasound to assess the hydronephrosis. CT urogram is a very useful tool. We do CT scan with delayed film. This 10 minutes after injection of the contrast. So we assess the ureter. However, the gold standard is retrograde ureterogram. We go with the scope and we inject the contrast directly inside the ureter. We assess the ureter, and at this time, if we found like ureteric narrowing or even sometime with the extravasation, we can try to insert ureteric catheter or double J stent that will be diagnostic and therapeutic. The question is when to repair the ureter. There is a lot of debate at this point. If we recognize the ureteric injury intraoperatively, we should go and repair it immediately. However, if it is recognized post-operatively, after the patient moved to the ward, here is the area of debate. Previously, they were saying within 3 days we can go. Now they are even extended to 1 week. If we recognize the ureter injury within 1 week, we can go for the repair. If we recognize it after 1 week, it's preferred to insert trial for insertion of double J stent or percutaneous nephrostomy to drain the kidney and to go for repair after 6 weeks, after the adhesion and inflammatory process subside. And one point about this one, because when we have a light ligature of the ureter, there is suture of the ureter. After 6 weeks, the suture might be dissolved. So it will make it even sometime after 6 weeks, we don't need to repair the ureter. The suture is already dissolved and the ureter maybe became patent again, or with minor stricture that can be managed by balloon dilatation or endourological techniques. The usual part, there is multiple options to repair the ureter surgically. The usual part of injury is the distal, the middle and the distal ureter. So this part, we can use direct reimplantation. We simply reimplant the ureter into the bladder on any area. We just connect it together. There is no consequences when where to connect the ureter. Or psoas hitch if the gap is long. I will show some images just before that to mention the principles that we have to mobilize the ureter carefully, so we preserve the blood supply. We should use spatulated, tension-free, stented, watertight anastomosis. We keep the ureter retroperitonealized, and we do non-tunneled anastomosis. I have some picture here. We can see the spatulation in picture C. We do just cut the ureter medially, so it will be very wide ureter. And we do non-tunneled anastomosis. Why non-tunneled? The usual pathology is the ureter is tunneled within the detrosal muscle, so to prevent the urine reflux. However, in injured ureter, we prefer non-tunneled injury because the reflux is harmless in adult and to avoid the ureteral stricture and stenosis. This is a picture of psoas hitch when there is a gap between the healthy ureter and the bladder. We can ligate the contralateral superior vesical vessel and push the bladder toward the psoas muscle and ligate it to the psoas tendon, so it will be tension-free anastomosis. What if we found a ligated ureter? The ureter is ligated within the uterine artery, especially in cases of bleeding. And we use a large needle. The ureter will be liable for ligation. If we can remove the stitch, that will be fine. That will be better. So we just remove the stitch. However, if the liability is a question, we have to go and do reimplantation or psoas hitch. I think our colleagues in intervention radiology can help a lot on this point to reduce the bleeding and make it easier for you to identify the uterine artery. This is a summary of the lecture just regarding the ureter injury. So if it is identified intraoperatively, the minor injury, we can go for stenting. Major injury, if the patient is unstable, we go for nephrostomy. We just ligate the ureter with long thread so we can easily identify it later and go for nephrostomy. If the patient is stable, we can go for reimplantation or psoas hitch. If the ureter injury identified postoperatively, if it is minor, we can try the ureteral stenting. That will be diagnostic and therapeutic. If it is a major, if it is within 1 week, we can go for immediate repair, either trial of double J stent or immediate repair. If it is beyond 7 days, we should go for nephrostomy and repair later. Just a conclusion, I think maybe the most common word here today is multidisciplinary team. We are at the end one team, and we are more happy to help in this spectrum. And there is an important role for the urology. There is almost 1/3 of the cases with urological consequences. And I think every institute should develop the local guidelines and policy to help to manage these cases. This is my references, and thank you very much. يعطيكم العافية. تعلمنا منكم دكتورة. الله يعطيكم العافية دكتورة. الله يعطيكم العافية. شهادة نعتز فيها دكتورة، الله يعطيك العافية. Yes, this is frequently reported, even for urological surgeries. This is when the bladder mucosa is disturbed, it will be liable for hematuria. We see it even in our surgery. This is quite frequent and expected complication of double gestant. Even some symptoms like urgency, dysuria, frequency, we expect these symptoms. As the double gestant is there will be hematuria. That's expected. After removal, after like 2-3 days, it should be stopped. But I think in the placenta previa with the pathology and the distended vessels and the compression of the bladder, this is expected to be there for some time. Thank you very much. الله يعطيكم العافية. دربت أنا في الرياض. بديت مكتبة طبية. الله يعطيكم العافية.
The ureter and avoid it during the surgery. And inshallah tomorrow in the workshop we do it. We have to open between the round, the ovarian ligament and the round ligaments, open and go deep before any clamp you put, identify the ureter. It's just about the bifurcation of the iliac fascicle, medial, above and medial to the uterus. So identify the ureter before any clamp. And this will save much of morbidity.
Yes, thank you, Doctor. I totally agree with Dr. Nawal that because of in this position, this frequent we have false passage. We as urologists, maybe we injure the ureter. And I think even with Dr. May and the other colleagues, sometimes we fail to insert the ureteric catheter. So I think, yeah, you're right. Identification of the ureter is more important, especially that the literature is clearly showing that ureteric catheterization will not reduce the rate of injury. It will just increase the rate of identification of the ureter. لا صراحة الأذر كوليج يزعلون يعني بس هم متفضلين علينا الله يعطيهم العافية ما قصروا. أنا عندي 3 أولاد كلهم انولدوا في الMCH الله يعطيكم العافية.
When there is injury and you start to repair it, by the time they will reach you, you already repaired the bladder. That's irritating for them because you already repaired something.
Yes.
We call them. And to feel safe and صراحة we as a surgeon لما أشوف كده bladder injury I cannot just observe and wait. يعني يتركني لازم أسوي repair. Especially إذا كان small وكبير المكان وكده بس إذا big ولا أو posterior مثلا لا ويستوي بس أنا استشفيت هذا العنصر اللي هو
صحيح يعني احنا sometimes it's difficult to identify the ureter post hysterectomy. The area is already ligated and there is a lot of adhesions. I think this is the most difficult part of our role.
I agree with you, Sarah, regarding we should learn how to place the ureter. طبعا تعلمناها من السينيورز أول من علم إياها دكتور راوي how to place the ureter. But still, sometimes I need distance because not always, especially if she is previous cesarean, so there is a lot of adhesions. Anatomy is distorted. So still I have difficulty in tracing. Still there is room for stent by feeling.
Definitely.
It is there. So it will help us.
Yeah, thank you.
Yes. But still, يعني near the cervix, still this is the critical area for me. When I tried it, I didn't identify where is the uterus.
الله يعطيكم العافية.
Yes, it's thank you very much. Technically طبعا أنا ده بالحياة practical. Sometimes it's very difficult حتى to identify a uric acid. It's okay. خاصة إذا كان يبكي very started to bleed عشان to go and to comfort. لكن technically هنا what we are doing. The problem is that usually the site of injury is when it is just below the uterine artery.
Yes.
Yeah? So if you just try to pull the uterus, the uterus is already outside, pull it up, and if you just push the bladder down, the distance between the lateral side of the uterus to the ureter is actually 2 centimeters, if I'm not wrong. It will be just it will be far away. Technically, this is for my junior colleague. And I just want to mention, I had one case, because you just mentioned there is no invasions of the placenta. One of my colleagues referred a patient with hematuria. She was pregnant, and the urologist did a cystoscopy and he found some pathology. He took a biopsy, it proved to be placenta tissue. And unfortunately, because he was referred by the obstetrician, and she was referred the patient to us. When we went inside, the urologist came with us, and even we did subtotal, we did, the urologist did a resection for that tissue. And recently, unfortunately, he was fighting that he is going to report the case that he didn't do it. Is there a issue? But it seems to me, once it has been reported,
You cannot say 100%. Maybe perforation during surgery.
Perforation of what? Cystoscopy, he should the obstetrician sent the patient for urologist for investigation. He got urine for investigation. Third trimester, he did a cystoscopy, he found something wrong, he took a biopsy, he thought it is a tumor. The histology indicated it's a placenta tissue. Then the patient returned to us, and then we proceed with the urologist, and we for intraoperative, the urologist, he did a resection for that tissue and he sent it also far. Anyhow, it's okay. Anyhow, once it is reported, this is definitely, we cannot say all reported cases is not true. It may be just your case, it may be just in the next years, we may find something like this. But it's okay, it's your. Thank you very much.
Thank you very much. Thank you very much.
Thank you so much for coming today, and hopefully you are looking to meet it more, inshallah, in the morning at the same time. It will be divided between the lectures in the morning session, and after that around 10:30,